perfectly with the expected outcome. There were no side effects. I enjoyed ease throughout the period of treatment. I declare that I am fruitful and I multiply. I declare that I am a fruitful vine and my children have surrounded my table like olive plants. I declare that I am planted in God. Therefore I flourish. I bring forth fruits, healthy fruits in all seasons. And
Good morning, everyone.
Good morning.
Please, can we move forward? If you have an empty seat in front of you, please, can you just move forward? Let's occupy the first half of the church, or the auditorium rather. Can we move forward, please? Thank you very much. Please move forward. If you have persons who are still outside, please send them a message. Tell them we're waiting for them. All right, please, let's settle down. Can we settle down, please? Please, let's settle down. Thank you. Ladies and gentlemen, good morning. I'm not sure you're here, and the lights, I can't see you. Are you there? Ladies and gentlemen, good morning. Fantastic. It is my esteemed pleasure to welcome you all this morning to the inaugural Fertility Conference of the TCN Isolo campus. I thought I would hear a round of applause. All right. You will agree with me that the topic of fertility is a very sensitive one. It affects people of all ages, parents, children, one way or the other. And so a lot of the times people are very, worried as to whether they are getting the right information per time. Let me give you a brief story. It's a very old story. And let's think through it together. This is going to be a very engaging session. So if you don't ask me questions or respond, I'll come to you with the mic. Do we agree? The eyes have it. Anyway, so let's imagine two seeds have been planted, same soil, side by side. There's a chance that both of those seeds will not germinate at the same time or grow at the same rate. Is that correct? Oh, I wanted to bring my mic to you. All right. They may not do well. They may not both, perform at the same time. Bring out your phones for me. Just bring out your phones. Bring out your phones. Bring out your phones. Yeah, thank you. Fantastic student. So if you have your phones, please bring them out. Please help me put them on silent. Thank you. Put them on silent. Thank you. If you need to make calls, we know that you might have important calls to make. Please quietly exit the room, make your call so that we don't distract others. For those who are coming to this auditorium for the first time, in case you would want to use the restrooms, we have restrooms for the kids at the back. You just go out this door, and then your left-hand side, there's some restrooms there. And for the adults, there are female and male restrooms on this side that you can essentially use. I would like to say that the topic we'll be discussing today, once again, is sensitive. And so if people have questions, I would like you to all respect, them as they share their experiences or their questions. Our experiences are unique, and it takes a lot of courage for people to ask questions and to contribute. So please, let's respect them. Without further ado, I'd like to quickly invite upstage our lovely, delectable, kind, sweet sister to give the official welcome address. Please join me as I welcome Dr. Adelopo.
All praise to God. Good morning, everyone, and welcome to Fertility Conversations 2026. Thank you. When we talk about fertility, we must understand two foundational truths. First, fertility is everybody's business. For far too long, we have relegated these conversations to the background because infertility doesn't always present as an acute bedridden illness. Yet, its impact is far-reaching, straining relationships, placing heavy pressure on marriages, and taking a profound mental and physiological toll. When we look at the clinical facts, 30% of infertility is attributable to male factors, 30% to female factors, and 30% to combined factors. There is also the 10% that remains unexplained. Let's just say the part where God passed you. Now, infertility is never a single person's burden. It is a shared human experience. So secondly, for our interventions to yield real lasting results, we must meet at the intersection of medicine and God's word, because informed faith changes outcomes. Now, as a mother, I feel the pain of waiting deeply, because we all have our stories, right? As the medical team of Covenant Nation Isolo, we share a collective passion for this conference because we consistently see preventable causes in our daily work as well as on social media. From improperly treated genital infections in our youth and unsafe procedures to delayed presentation for reproductive checks. That is why we are choosing to close the information gap today and guide you step by step towards your own miracle. As a Christian medic, I have seen the hand of God at work far too many times. Even in advanced procedures like IVF, after the embryo is transferred, we doctors reach our limit. We step back, and God takes over. There is the waiting period. I have personally managed a 53-year-old woman who carried her pregnancy to full term and delivered a healthy baby, both mother and baby healthy and thriving. If God can do it at 53, your story is far from over. That is the message we want to give you this morning. It is no accident that you are here today. The time for passivity is over. I want you to get on that line, pen your name down, take advantage of all the experts gathered here today. Approach every session ready to learn, to pray, and ready to act. Of course, pray we must. But what is faith without works? Leave behind fear, take hold of knowledge, and step boldly into your testimony. Remember again that informed faith changes outcomes. We are deeply grateful to our pastorate and our distinguished faculty of experts. I stand in faith with you today for testimonies, signs, wonders, and of course, baby cries. Amen. Welcome to the maiden edition of Fertility Conversations 2026, hosted by the Covenant Nation Isolo. God bless you all.
right? Okay, thank you. If you've ever called your parents to say, I don't understand my body, right? I've just seen something and it's quite new to me. Or said to your spouse, please call your mother. Please put your hands up. Nobody. It seems you are all knowledgeable. Oh. Has anyone here had to wake up at night and Google and say, there's something I saw that I don't really understand? If we have those groups, have you called your sister to say, or brother to say, you are more experienced than me in marriage, oh, how did you handle this? Do we have anyone? Oh, you're the firstborn. Okay, your friends. All right, have you gone to a WhatsApp group filled with women talking about their pregnancies and you leave a comment and then you quickly ask, what about this? What about that? How many people have relied on WhatsApp platforms? Okay. I think we have the right people in the group, in the room. We'll be going into the next session and, we're starting our deep dive to really learn from the team of experts that we have this morning. There'll be some presentations. Please listen attentively. We'll take questions later. I have some, incentives that I think you would like to know about. If you remind me later during this session, I'll tell you a bit more about it. But right now, let's focus now on the speaking sessions.
She is a consultant pediatrician, a pediatric neurologist at Duchess International Hospital, Lagos. She trained at the University College Hospital, Ibadan. Of Nigeria in pediatric neurology. Her clinical and research interests include pediatric epilepsy, neonatal encephalopathy, and stroke in children. She has published in developmental medicine and child neurology and the Nigerian Journal of Pediatrics and is a recipient of many awards, both national and international. She is an active member of the Child Neurology Society of Nigeria and the Nigerian Society of Neurological Sciences and has presented at the American Academy of Neurology and British Pediatric Neurology Association conferences. She is a child of God, a member of the Covenant Nation in Ikeja, where she serves. She will be speaking on a pediatric guide to protecting your child's fertility, understanding how undescended testes and congenital structural abnormalities in children can lead to infertility later in life. With a round of applause, please welcome with me Dr. Oreoluwa Lagunjo.
Thank you very much. I must return all the glory to God for this great honor and for the good things that He has done in my life. I thank Him, the giver of every good thing and the giver of the best gifts in life. I'm a woman who has been tremendously helped by God, and so I return all the glory unto Him. I thank the leadership of this branch. I thank the leadership of the medical unit. Thank you very much for this honor. I also thank the leadership of my campus, Dr. Yemi Oshonaike, for his release and his blessing. It's good to see, I greet my co-panelists, my co-speakers. It's good to meet you again. Holy Spirit, we ask that as you've been doing, we ask that you show yourself again this morning. I ask that you speak through me, speak through my words, cause me to minister grace to everyone who will be listening to me. I ask that you rest upon my countenance. And I ask that beyond this being an intellectual discourse, it will be an avenue for the supernatural visitation upon every home and upon every heart. In Jesus' name, amen. Okay, so I'll be discussing the theme, protecting our children's fertility. I think the slides will be going on as I speak. So we all know that infertility is now a growing concern in many homes. I'm sure that each of us knows 1 or 2 or 3 couples who are dealing with infertility. Statistics have put that 1 in 6 couples will struggle with infertility, either primary or secondary. So either they're trying to conceive at first to achieve pregnancy for the first time, or for the second time, or the third time. And now they're growing contributing factors to this, which we would learn further in the discourse. What are some misconceptions that need to be debunked? The first is that you can't get pregnant the first time you have sex. Now, this is wrong. Although most of the periods that a young lady would have are said to be anovulatory, meaning that she would not be ovulating yet. I mean, that's just when she attains puberty. But pregnancy can still happen. So a 14-year-old girl can get pregnant. A 15-year-old boy can get a girl pregnant. Phones, tight underwears, hot baths do not affect sperm. That is not correct. Infertility is not only a woman's problem, as there's also the male contributing factor and even the combined factors. And moms in adolescence actually matters. We would learn that as we go along. So why do we need to know this early? Why do young parents need to take note of this as they're raising their children? It's because fertility is shaped long before adulthood. Everything that a young man, a young woman need to become fathers, to become mothers, already in the baby when the baby is born, structurally. So they're not just going to come. The female baby already has all the eggs she would need for her lifetime. The male baby has the testes, maybe not the sperm cells yet, but the testes. So structurally, everything that is needed to achieve conception, to achieve reproduction later in life are already present in the babies. And then, of course, children, adolescents, and so there's the need to really take note of what may go wrong early. So the next slide shows we're about 2 slides now. The next one, please. Okay, so this was just what I tried to illustrate, that the structures are already present at birth. Now, puberty marks the point where a child reaches sexual maturity. So even though these structures are present at birth, the hormones responsible to make them develop, to make them ready to achieve pregnancy, to carry a baby to term, are quiet until puberty. And so at puberty, there's the signal from the brain that, okay, the puberty is setting in, this person is getting mature. Can you start developing? So to break this down, let's assume there's a chair manufacturing company and there's a demand for chairs in a company at Ilupeju, and you have the general manager, the line manager, and then the foot soldiers, the factory workers, the ones who would actually produce the chairs. And the general manager calls the line manager to say, oh, there's this demand for just a number of chairs at this organization. Can we start making it, can we start the production? And the line manager gets in touch with those who would actually make the chairs. As they start the work, oh, how far have you gone? 50. Oh, we need more wood, we need more supplies. And then when they hit the 120 mark, they say, oh, now we've produced 120 chairs. And the signal back to the general manager, and the general manager says, that's fine, let's halt production. So that's the same way the hormones play out in puberty. So there's a signal from the brain to the pituitary gland to produce hormones that would act on the ovaries and on the testes to begin to produce hormones that would bring maturation of the breast, the uterus, the ovaries, the vagina, and also for the males, it's responsible for the difference in the testes and the penile length and all that, and even in their voices. So when puberty happens, this process has a sequential, there's a sequence to it. So for the females, please, can we keep rolling the slides? The next one, please. Okay, sorry, the one before that. So for females, they attain puberty between age 8 and 13 years, and males 10 and 15 years. So 2 slides, the next slide, please. The next one. Okay, so this just illustrated what I said now, and then the next one. Okay, so in the females, they start to have breast buds first, and then acne, what we call pimples, and then they develop hair under their armpits and in the pubic region. They experience a growth spot, that means they grow taller, and then they start to see their periods. For the males, they have testicular enlargement first, that's the balls start to grow first, and then they develop the hair in the armpits, the pubic region, and then the penis begins to grow in length. So all these changes occur as a result of the hormones that are being produced during puberty. If anything goes wrong between the communication between the general manager and the line manager, or between the line manager and the factory workers decide to go on strike, or there's no network in communication, this can disrupt puberty, and if it's not halted, it can result in infertility. So for the females, the hormones responsible start to grow the eggs. Like I mentioned earlier, the eggs that she needs are already in her when she's born. They start to develop, and then one becomes fully mature and is released into please the next slide. And the next one. Okay, so the ovaries are located on the 2 sides of the uterus. One ovum is released every 28 days when it attains full maturity. It travels through the fallopian tube and into the uterus. If there is no fertilization, then it's shared as a period. For the males, during puberty, the testosterone starts to, the FSH starts to produce sperm cells. The sperm, during ejaculation, the semen travels and comes out through the urethra. So that was the reason for the repeat picture. So what are some things that can go wrong in children that may impede fertility? Now we're talking about the males. So 2 slides. Yes. So studies have shown that 1 in 25 boys born at term would have undescended testes. So boys have 2 testes in their scrotum. If there's one missing, it means that one hasn't descended into the scrotum. It usually it can happen in 1 in 25 boys that are delivered at term. In some other situations, the testis has descended, but it goes up and comes down by reason of the contraction of some muscle. So it goes up, comes down, goes up, comes down. We call that retractile testis. In that situation, we wait till puberty and it will naturally descend on its own and stay where it should stay. For the ones with undescended testes, we watch them until age 12 months. If it does, because majority would descend by then. If it has not descended, surgery must be done by 18 months maximum to bring down the testes. And that's because the testes, there's a temperature that is just right for sperm cells to be produced. If the temperature is increased, if it is more than that, it affects the sperm-producing cells and affects the quality of the sperm. If the testis remains in the wrong location long enough, it may cause malignancy. It may turn into a cancer cell. What are some other structural things in men that may cause infertility? Hypospadias, epispadias, and this is where the urethral opening, that's the opening at the tip of the penis where urine comes out from, semen comes out from, that opening is now or on top of the penis or under the penis. So invariably, it would affect ejaculation. So instead of semen coming out from the tip, semen will be coming out from the side, and the semen may even go back, what we call retrograde ejaculation. So, and in some other cases, the penis is abnormally formed in addition to this abnormal opening. So the penis may curve. This structural condition can affect infertility because the penis would not be able to deliver the semen where it should deliver the semen into. Another thing is varicocele. Please, can we move the slide? 2 slides, please. Okay, maybe there's something wrong. The next slide, please. Okay, so varicocele is when the vein surrounding the scrotal sac is enlarged more than usual. And we know the blood vessels, there's some form of heat that's already been produced. So if the vessels are larger than usual, it would increase the temperature and it may affect the quality of sperm cells that are being produced. Inguinal hernia on its own would not cause infertility, but if it is present with some of these other structural conditions, it may impede fertility. Another condition is differences of sex development. So this baby is born and we look at the genitalia and we can't tell if it's a boy or a girl. The clitoris, that baby would have a clitoris. Clitoris is the part of the female external organ that gets excited during sexual intercourse. So this part of the baby is bigger than usual. One may feel some round structures in them by the side, and then there's a stump that is supposed to resemble phallus, but it's not exactly the phallus. So there's usually a confusion if this is a female child or a male child. So for one, of course, it's easy to reason that infertility there'll be a very high risk of infertility in such children. The benefit, however, is that it's rare. It's not that it doesn't occur, but it's seen in about 1 in 2,000 to 5,000 children. Other acquired factors include mumps in adolescents. That's when the cheeks are swollen and a bit tender, either one side or both sides. And reports have said that if it happens in adolescents, 3 or 4 out of 10 boys, it would affect their testes. So it's something that we need to take note of. Poorly treated sexually transmitted infections like gonorrhea or chlamydia, then testicular torsion, or if there's malignancy, if there's a tumor in the testes or there's a tumor somewhere else in some other part of the body and then sends deposit to the testes, then of course chemotherapy, radiotherapy may affect it. Studies have also shown that obesity can affect the production of testosterone and invariably the quality of sperm cells. So parents, please take note of that. We need to watch what our children eat. So how do we treat some of these conditions? For the undescended testes, I've talked about watchful waiting, but surgery must be done by age 18 months to bring down the testes. For some other conditions like mumps would need treatment, antibiotics, and some other hormonal therapy for the ones with sex differences in sexual development. We move on to the girls' reproductive health. They have, unlike the men, or unlike the boy child, you can easily spot when something is wrong. So if there's undescended testes, you can tell. If the urine is coming out from somewhere else, you can tell, even way before they reach adolescent stage. But for females, it's really hard to tell. It's only what is outside that one can see. What is inside may not be visible. And some females are born with some changes in the structure of their wombs and even the vagina. So for the next slide, and the next slide, please. The next slide. So for some, the uterus has this like tissue in between, but thankfully this doesn't affect conception, and some women have been able to carry babies to term. Another thing is imperforate hymen. So the vagina is sealed. The female child would have this pain every month, like period, but there's no obvious bleeding. There's no overt bleeding. There's some genetic conditions like Turner syndrome where the child is born with some defects physically, and the ovaries are very small and even dysfunctional. So these are some of things that one will need to take note of, parents will need to take note of. So how do we screen this? How can we intervene. Like I said, most of the time, this, for the females, unfortunately, is not detected until they get to puberty and it's like, where is menstruation? We're looking for it. So for them, that's when they now seek help. They go to see the gynecologist. If there's a need for surgery, they have surgery. If there's a need for hormonal therapy, they have that too. For the females, other acquired factors include unsafe abortions. So when there's instrumentation into the uterus and it causes some damage to the fallopian tubes or whatever, it can affect fertility in the long term, as well as untreated STIs, poor lifestyle habits, obesity. Again, we will learn from PMOS how insulin resistance affects ovulation. So what can we do to protect our children's health? Early checks. Parents must be vigilant. So beyond the pediatrician doing the initial assessment of checking the testes, I remember when my youngest godson was born and his father is a pediatrician. He was outside the operating room because he was delivered via C-section. And the only thing he shouted from outside as soon as he heard that the baby was crying was, all right, please check the balls, check the balls. So I'm like, inside everything that is going on in this, it's balls that is important to you. But because he knows the long-term implications. So parents must be vigilant. I had another patient about 2 months ago, female baby, I think she was now 6 weeks, and the mother came and said the vagina was closed. I said closed. Oh, no, yes, I'll just say like that, or the external genitalia. And the baby was delivered in our facility, so we would have checked. And the mother said, oh, yes, that even when she got home, she also has been checking. She's been checking every day because this is her first girl. She's had boys. And that it closed. And indeed, it was also had to call in the gynecologist. And she had this labial agglutination. That was the first time I was hearing about it. So it's important that parents are vigilant. Open talks. Let's leave room for conversations with our children so that we know who is touching them, who they are liking, what they're able to do, what their preferences are, and we need to be good models to them. They see us, they see how we relate with their father, with their mother, and they emulate us subconsciously. So we need to model purity and respect. Good nutrition, I've talked about the role of obesity in infertility. It's important that we give them good nutrition. Vaccines for the STIs or the diseases that are preventable, like the moms, we have the MMR, HPV for the females. Now, what to remember? Fertility begins in childhood. Majority of damage occur early, and so early recognition would encourage prompt intervention and will be able to salvage some of the cases or some of the causes of infertility. It is God who gives children at the end of the day. There's no doubt about it. Because even to say infertility means that they've been the couple has been having sex for a particular number of times before we can see infertility. So it's God invariably that gives children. Our bodies are his temples, and so we must take full responsibility for what God has given us and protect what God has given us. So let me be a messenger of hope to somebody today. Somebody waiting. Some people are in their minds are like, this one that you're talking that we should be looking at. So even if somebody has boyfriend or girlfriend, I say, we will be checking something when they are, but there's even nobody. So for as many waiting for life partners to start their homes, to have their own children, do not fling away your fearless confidence, for it carries a great and glorious compensation of reward. The husband will come, the wife will come, the children will come, they would even come in their multiples, so you had better be ready, and every other good thing will come. Thank you very much for listening.
Thank you. Things she mentioned that I want to emphasize is that there are structural, the structural formation of the children's genitalia is very important that we look at those while they are still kids. Someone said to me to whisper to the men that when the boys come to you and say, I have pain down there, the answer is not paracetamol, it's let's go see the pediatrician. And to the women, as you take care of those children, please be observant and, spot these issues early enough so that they can be addressed very early on. We'll be moving the conversation further. The next speaker will be giving us new perspectives in this conversation.
She is a consultant obstetrician and gynecologist based in Lagos. Wellness. Her practice focuses heavily on improving maternal perinatal outcomes. She possesses vast hospital in Lagos. He earned his medical degree from the Ladoke Akintola University of Technology before completing his rigorous residency at the University College Hospital Ibadan. As a distinguished fellow of the West African College of Physicians, he brings extensive expertise in comprehensive patient care and preventive internal medicine. Highlighting his commitment to clinical excellence, he holds specialized certifications in leadership and management in health from the University of Washington. His broad clinical background equips him with unique insights into the systemic lifestyle and physiological factors that deeply impact male reproductive health. A passionate advocate for holistic well-being, he routinely educates men on proactive strategies to maintain long-term physical and reproductive vitality. He joins us today to share his comprehensive medical perspective and provide actionable insight on the critical topic of safeguarding male fertility. Without further ado, please join me in welcoming Mr. Dr. Adeboyega Alao with a big round of applause.
Good morning, everyone. Yeah, so thank you for the introduction. As rightly introduced, I'm Dr. Alao. I'm a family physician, and I'm very glad to be part of this conversation on male fertility. I've been assigned the topic to talk about safeguarding male fertility. That's protecting the gift of fatherhood. Okay. All right, so at the end of this discussion, I hope that we'll be able to understand what male fertility is, identify the common causes of declining male fertility, to be able to recognize lifestyle and environmental factors affecting fertility, and learn practical ways to preserve fertility. Of course, appreciate the role of faith, healthy living, and timely medical care. Okay, I don't mind. Thank you. All right, so why the conversation on male fertility? About 1 in 6 couples, experience fertility during their reproductive years. If you think about that very well, that's a very huge number. Male factor contributes almost half, if not half, of infertility cases. And then, in Africa, infertility carries a big emotional, social, and spiritual consequences. And women often take most of the blame for infertility. Okay, so what do we know about male fertility? It refers to a man's ability to produce viable sperm capable of fertilizing a woman's egg. And that depends on, adequate sperm production, good sperm movement, what we call sperm motility. The sperm also must be normal in shape. The DNA of the sperm must be normal as well. Then it also depends on the reproductive hormones. And of course, the reproductive tract in the male must not be obstructed. Then there must be normal sexual function. All this, help to achieve good male fertility. So just the basics of male fertility, like I said, the number must be adequate, the motility must be right, the DNA must be good, the shape must be fine as well. We had some percentages or some parameters we look at when we ask the men to do a semen analysis. Then these are the hormones involved: the testosterone, the follicular stimulating hormone, luteinizing hormone, and the gonadotropin releasing hormone. So sperm is produced in the testes, we all know that. And it takes about 74 days from production to maturity in the testes. Testicular function, it's best in lower temperatures than the body temperature, about 2 to 4 degrees below the body temperature. So the testis functions best at this temperature. And it's important that, we maintain continuous healthy lifestyle in order to preserve the quality of sperm, that is produced in the testis. How does pregnancy happen? There has to be, healthy sperm cells. There has to be ovulation on the side of the female partner. The fallopian tubes must be patent. The uterus must be healthy. And then the timing must be correct. Failure in any of, these steps would result in infertility. So there's no way we'll talk about fertility and not talk about infertility. Infertility, by definition, is failure to achieve pregnancy after 12 months of regular, unprotected sexual intercourse. We use 6 months for women who are 35 years and older, generally. And 2 types: primary infertility for couples who have never conceived before, the woman especially. And then secondary infertility means there has been a previous pregnancy, but there's difficulty in achieving another pregnancy. So we know that, especially in this part of the world, it can cause significant distress, stigma, even financial hardship among couples. And this can affect the mental health of the couple, it's psychological well-being, expressing or, showing has depression, anxiety, marital strain, and reduced self-esteem. Okay, here are some lifestyle habits that can harm male fertility. Smoking, excess alcohol, recreational drugs like marijuana, cocaine, even anabolic steroids being used by, bodybuilders. All these can affect the quality of sperm cells produced in the testes. Yeah, obesity is another problem, another factor that can affect the quality of sperm cells. They do that in different ways, affecting the hormones, affecting the the genes or the chromosomes in the sperm cells. The other factor okay, sorry, I think I missed a slide. All right. Sorry, this is not responding the way I want it to be. Okay. So exposure to environmental toxins is another problem. You know, usually people will deal with insecticides, herbicides. You know, if you are not well protected against these chemicals, they have a way of, you know, reducing sperm production and the quality. So it's important that we use protective equipment adequately when we are dealing with the use of these chemicals. Then the next one, there are several medical conditions. Some of them were mentioned by Dr. Lagunjo earlier. Varicocele, diabetes, hypertension, sexually transmitted infections. All these are, you know, various medical conditions that can affect the fertility in men. And it's important to identify them early and get them treated. Like I said, this is some of the infections of the reproductive tract that can, you know, impede fertility in male by blocking the reproductive tract. Okay, so then there are some medications too, you know, like some cancer medications, like I mentioned earlier, anabolic steroids being used by some bodybuilders. You know, it's very detrimental to the male fertility. So exercise, moderate exercise is very good. It helps to improve the hormone balance, helps weight control, improves cardiovascular health as well in general. And it's important that we avoid steroid use for bodybuilding. This is the third time I'm mentioning that because it's a very common thing in most gyms now. And of course, excessive, you know, exercise too has a way of impeding male fertility. Yeah, so sleep is also very important in restoring or helping the male fertility. It's important we get about 7 to 9 hours of sleep every day so that the sperm quality can be improved on. Stress reduces libido, alters the reproductive hormones. So we should all learn how to, you know, manage stress effectively. So when should a couple seek help? Yeah, so a couple should seek help immediately, especially if there are problems, you know, already happening. If there's erectile dysfunction, previous testicular injury, patient is on some medications, or there's history of chemotherapy for cancers, there's undescended testes. Those are immediate concerns that need to be addressed. Otherwise, younger couples where the woman is less than 35 years, you need to have, you know, have regular unprotected sexual intercourse for it. So you would generally want to wait for that period, because most couples will get pregnant within that period by just being patient. And it's important that both partners are evaluated together, not just the woman or the man alone. Okay, so when the man presents at the hospital, the doctor will go through, you know, all these in order to assess where the problem is, ask a lot of questions, examine especially the testes, then order some investigations, especially the semen analysis. could hold some hormonal profile, blood glucose checks, screening for sexually transmitted infections as well. Okay, and treatment will depend on, the identified causes, and the options include lifestyle modification, treatment of infections or underlying medical conditions, treatment of hormonal disorders, varicocele surgery in very selected patients, and of course, IVF is also an option, depending on what the causes. Here are some of the myths, that people talk about that are not really true. Dr. Lagunjo mentioned some earlier. The first one is infertility is always a woman's fault. That's not true. We know that's not true because male factors also account for nearly half of the cases. A man with many children cannot become infertile, but that's also not true. Fertility can decline even later in life. Sexual performance is not equal to fertility. They are completely different things. Someone they can perform very well sexually, but may be infertile. So it's better to get checked. Then herbal remedies always work. So that's also not true. Many of these herbal remedies, lack scientific evidence and may even be harmful or worsen infertility. Prayer alone is enough? Yes. Not totally true. So faith and medical care, they work hand in hand. While we pray actively, we should also seek medical help. Okay, I won't go through all this because of the time. These are just some of the things I've mentioned earlier about safeguarding male fertility. These are just some practical steps, regular exercise, healthy sleep, stress management, staying hydrated always, avoiding substance use, preventing hasty highs, and then good control of our blood glucose and blood pressure. Like I said, God has called us to stewardship of our bodies, because our bodies are the temples of the Holy Spirit. So we have to take care of God's temple. Faith encourages healthy living, wise decisions, seeking medical help, supporting couples compassionately, and praying without the stigma that comes with infertility. Medical care and prayer work together rather than compete. In conclusion, I'll just leave us with these messages. Male fertility is an important part of reproductive health. Male fertility problems are very preventable. We just need to pick them to know what's actually wrong and then get treated. Then lifestyle changes today affect fertility months later. Lifestyle choices. Early medical evaluation improves outcome. Let's protect our fertility even before we need it. And that was what Dr. Laji was trying to say earlier. Faith inspires responsible stewardship of our health. Thank you very much for your attention.
Thank you so much.
It's very important, right? Please stop putting laptops on your I'm very serious. It's very important. The ladies are trying to, do their part, Anyway. All right, and please let's avoid the chemicals that can affect us. Thank you so much, Dr. Alao. We've talked about children's health and how we can safeguard their fertility, and we've looked at it from the male perspective. Now we will look at it from the female perspective and also consider family planning, which is for everyone, and then PMO. Over to the next speaker.
She is a consultant obstetrician and gynaecologist. various reproductive health challenges. As an active medical researcher, she has authored impactful studies in reputable publications such as the African Journal of Reproductive Health. Our academic and clinical work frequently addresses critical areas like fetal congenital anomalies and tailored care for adolescent mothers. Beyond the hospital, she is a dedicated public health educator who regularly speaks at Women's Forum and hosts institutional health webinars. She has actively championed initiatives aimed at expanding access to specialized maternal care for vulnerable and marginalized groups in Nigeria. Driven by a passion for preventive medicine, she strongly advocates for evidence-based family planning and comprehensive fertility care. Today, she shares her hands-on experience to clear up the facts about family planning, PMOS, fibroids, and getting pregnant. It is with my great pleasure to invite you all to join me in welcoming with a big round of applause, Dr. Adesimbo Koinsola Odeshere.
Apologies. Oh, yes, this is better. Okay. All right. So, infertility and women's health is very broad. So my task is a lot. But today I've been assigned with the responsibility about the misconceptions regarding family planning, PMOS, fibroids, and and your journey to conception. So we'll stick with that. Otherwise, we can be here literally for the next 4 hours. But before I start on that, let me just quickly talk on how fertility happens. And I really liked something Dr. Amaro said about patients being a major factor in the fertility journey. And I'll just give us a bit of science around why we talk about regular, unprotected sexual intercourse. In this Lagos, how now? But this is why we say that. Once a woman ovulates, that egg that is released survives for 24 hours. When a man ejaculates his sperm, the sperm lives for about 72 hours. And so when we say regular unprotected sexual intercourse 2 to 3 times a week, what that means is that in whatever time of the ovulation that occurs, if a couple is having sexual intercourse 2 to 3 times a week, that egg that is released, that lives for 24 hours, and the sperm that survives 72 hours, somewhere along the line, in that 2 to 3 times regularity, they will meet. When that happens, 80 to 85% of women, or couples, I beg your pardon, will get pregnant within 1 year. Which is why we say, if you don't already have a background concern, do not come to the hospital until 1 year of regular unprotected sexual intercourse, because you need time. It's such a complex process. Dr. Lara has talked about, the brain has to release some hormones, and then Dr. Lagunja has given us how the structure of the male part and the female part occurs. In every cycle, it takes, the success rate of fecundability is just about 30 to 35%. What does that mean? You need the regularity of sexual intercourse so that we don't give ourselves high blood pressure. And so after 1 year of that, if that then hasn't happened, then you can start seeking medical help. Of course, this is for the normal general population. If you already have an underlying health condition, please do not wait 1 year. If you're older than 35 years of age, please do not wait 1 year. So let's dive in today to the conversation about family planning, PMOS, fibroids, and the misconceptions that go with that. It is not responding to me. Goodness.
Okay. Right. So we're just going to take it very simply. What are some of the myths around conception? That conception is instant, simple, and any delay is purely a physiological. And that's why I spent a couple minutes just trying to explain how that works. So I think from that we can see that this myth is baseless and it takes time, and the whole cycle of how fertility occurs. For uterine fibroids, it's an interesting one. Uterine fibroids are quite common. Statistics say about 7 to 8 in 10 women will have fibroids. And it's not just an African thing. Yes, it's commoner in Africans, but it's all women of all races, Caucasians, Asians, and the rest. But it is commoner in black women. So it is our thing, and 7 to 8 in 10 women will have. But not all women who have fibroids have a problem. Not all women who have fibroids will need to have it sorted before they can get pregnant. Many people go along with fibroids and get pregnant. However, if the fibroids are causing concerns, then it needs to be addressed. And it's not really just about fertility alone. Even for the quality of your health, fibroids has many other symptoms beyond fertility. Fibroids are not cancerous. They are mostly benign. Benign means not cancerous. They grow from the lining of this diagram is not very clear, but the uterus has 3 layers. The middle layer is made up of muscles, and then the fibroids tend to grow from there and can occur in any of the layers of the uterus. What about PMOS? Up until this year, it was known as PCOS, and the rename was done. Nothing has changed about it. They've just coined it a better terminology to appropriately describe all that goes on with it. So we don't assume it's just about ovulation and it's just about ovarian function. PMOS is now polyendocrine metabolic ovarian syndrome. It's not strictly an ovarian tissue, and it only affects women when you're trying to conceive. Absolutely not. The symptoms that go along with it will be irregular menstrual periods, sometimes heavy menstrual bleeding, and very importantly, as a woman grows older in life, there are long-term health implications of PMOS, which could include type 2 diabetes, which could include endometrial hyperplasia that can increase one's risk of cancers later in life. So the focus shouldn't only be about fertility. I'm a firm believer that women are more than just childbearing instruments. We are human beings. We are complete in ourselves, with or without children, with or without marriage. God created us as human beings for his purpose. So our entire existence cannot be narrowed down to just fertility. And so in whatever health concerns that we're dealing with, in as much as they can impact fertility, they can also impact other areas of our health, and we should pay attention to that as well. So it is a systemic endocrine and metabolic condition that can impact other areas of our life, including fertility. So how do we manage it, and how does it impact fertility? The major thing about PMOS and fertility is that one will not have monthly menstrual cycles because one is not ovulating monthly. So what that means is that it takes a while for the follicles to gather themselves together to grow enough for one to stand out to then be released as a mature egg to meet a sperm at its viable time, which is why sometimes randomly, even a woman with PMOS, and lots of women with PMOS still get pregnant spontaneously because the eggs are doing their thing, and then in one random cycle, one egg manages to grow big enough to get released, and then you can get pregnant. However, if the pregnancy is then not occurring, then of course you've got to see your gynecologist, and there are different methods that we can use. And it's not always about assisted reproduction. Sometimes, and I like the conversation Dr. Olagunjo and Dr. Alao have emphasized, obesity is going to show up here again. Obesity is a big deal when it comes to PMOS, and many times, just losing that weight alone is enough to return spontaneous ovulation, so you don't need to spend lots and lots of money to go down, fertility route. So sometimes we start simple, and then we go along the algorithm, and then if we need to then do more complicated things or more advanced things, then we will do them. So dietary adjustments, exercises, using some insulin sensitizers, all of that is geared towards trying to re-regulate the hormonal imbalance that has been occurring that would then allow you do spontaneous ovulation that can then give us fertility. What about family planning and long-acting reversible contraceptives? It will take me back to the definition of primary infertility and secondary infertility. And secondary infertility is defined as the inability of a couple to achieve pregnancy after previously having had a baby. Now, there's a lot of debates as well about secondary infertility and its definition. And as of yet, there isn't a general conclusion. Because sometimes is that the woman has gotten pregnant before with another partner, and then now she's with another partner and she's unable to get pregnant. Would we define that as primary or secondary infertility? Schools of thought are divided. Some will say, well, since it's a new parent, we will define it as primary infertility. Some will argue that since the woman has been pregnant before, then it is defined as secondary infertility. It doesn't really matter. What is important is in that moment, that couple cannot get pregnant and needs to be evaluated. And a lot of the conversation is about, oh, I don't want to do family planning because I don't want to affect my fertility later in life. Let me not get pregnant. So let me, not do anything. But the bigger concern or the bigger thing to think about is then the importance of family planning is to help you space children. I've talked about the woman being a complete person in herself. It's not good medically, mentally, emotionally, even for the woman's career growth, whatever she's doing, to get pregnant back to back to back. A woman needs time to recover. Pregnancy takes its toll. 9 months breastfeeding, you lose a lot of blood, you lose a lot of hormones and all of that. You need time to recuperate to get pregnant. Sometimes you're not even ready to get pregnant because you're doing other things. And that's where family planning comes in. And so my job today is to help us realize that family planning is not a deterrent to fertility, and it solves its own things. And so most of the family planning methods that we use now, we refer to them as long-acting reversible. And that takes me to the point that in using it, it doesn't mean that you can't get pregnant when you want to. Because the aim of a long-acting reversible contraceptive is once you're done with it and you want to get pregnant, once you take it out, your return to fertility is immediate. So the types that we use usually is either the implants or the IUDs, and there are 2 types of IUDs. That's the intrauterine device, copper T device. There are 2 types of that one, the hormonal and the non-hormonal, and then we have the implants. Either of those 2 methods are effective, and once you take them out, in your very next cycle, you can get pregnant, except there are other attenuating circumstances, but a delay in fertility is not usually going to be as a result of the family planning method you used. Now, if you use your family planning method well, as you should, then 99% are protected for the duration in which you use it. However, I had a patient once who she had an intrauterine contraceptive device inserted. I delivered her 2 children, and it was after the second one. She had both children by cesarean section. So we put in the IUD, and then she was living her life, doing her thing. And then, I don't know if anybody has heard of menstrual cups. Females, anybody? Menstrual cups. So she decided to switch from regular tampons and pads to using menstrual cups. And then, the menstrual cups works by suction as well. So she put it in and then she was using it. And then with suction, it displaced the IUD. I know, she was so traumatized. And she came back pregnant. Even I was traumatized because the 2 of us together, how do you, but it didn't mean the contraceptive failed, did it? No, it didn't fail. It was just, other circumstances. If you're Yoruba, Okoba, but, the good news for her was her first 2 were boys, so this one was a girl, so hey, everything worked out. So the point is, if you use the contraceptive the way it should be used, it shouldn't fail you. Nothing in science is 100%, so let me stand on that. 99%. A 1% will get pregnant. I don't know. Maybe God has assigned them for specific reasons. But, 99% is a good deal to please go ahead, use your family planning if you need to. And I think the point I should emphasize on today's conversation is it won't impact on your fertility. It won't make you not get pregnant. Sometimes there are other types that may delay fertility for a couple cycles when you're using the pills, the combined oral contraceptive pills. But we don't tend to use those ones as long-acting reversible. But even with combined oral contraceptive pills, they don't tend to delay fertility for long. Right, I skipped over talking about fibroids well. So let me go back to fibroids. I think I have about 5 minutes left. Okay, so good. So let's talk about fibroids because I know that's a big deal. I'm so not happy this diagram is not showing very well. Okay, but fibroids. There is this myth about once you have fibroids, then that means infertility is likely. No, not likely, because I mentioned earlier on that lots of women do have fibroids and go on to have their babies, no problem. So what do we do as gynecologists? A woman has fibroids, we evaluate. And many times, for a lot of women, they don't have symptoms. We leave you alone if you don't have symptoms. What are the common symptoms of fibroids? Heavy menstrual bleeding, painful periods. Sometimes your tummy starts getting bigger, that sometimes people think that you're pregnant. Other symptoms of fibroids can impact, frequent urination because it's a growth in the tummy and it can get bigger and bigger. So sometimes urine gets affected. You find yourself urinating a lot more often. Sometimes it's, constipation, alternating with, frequent loose stools. Sometimes it's your leg getting swollen because there's this thing sitting in your lower tummy and your blood vessels are supposed to drain blood from your lower, body back to your upper body. So if there's like an obstruction sitting there, it can kind of make blood pool or fluid pool, and then your legs can be swollen. So those are some of the symptoms of fibroids. So if you have any of those symptoms, then yes, we'll be evaluated and decisions for treatment. And there's a wide range of options of management. That's not today's conversation, so let me not touch it. Now, there's a subset of women who have fibroids. They've been trying to get pregnant. They're having sexual intercourse 2 to 3 times every week. It's not happening. If you've done that for 1 year and we've evaluated, Dr. Lau has given us a beautiful overview of the tests that we tend to do for fertility. We've evaluated, we don't see anything else. Sometimes we decide to go and take out the fibroids because it could be the factor. Now, the direct instances in which fibroids could be implicated will be if the fibroids are sitting over the opening of the tubes. We've talked about how fertility occurs. The egg has to be released, the tubes pick it up, the sperm meets the eggs in the tube, fertilization occurs, and then that fertilized egg travels back into the uterus. So except that you have fibroids sitting on the opening of the tubes on both sides, that one you can't run away from it, that one is direct. But it's very rare because in any cycle, you just need 1 egg, 1 tube to be able to get pregnant, because usually in every cycle, it's just 1 ovum that releases its egg. And then in another cycle, it could be another one, it could be the same one. It's not likely, except we're giving you specific medications, it's not likely that it's both ovaries that will release the egg, and it's not likely that it's both tubes that will pick up the eggs. So except you have fibroids sitting, blocking the opening of both tubes, then that's direct. So you can't run away from that. Or sometimes you have fibroids within the lining of the womb. The lining of the womb is where the baby ends up being implanted. We call those type of fibroids submucous fibroids. It's meant to be shown somewhere. Maybe they'll give you the slide so you can have a look at those. So if you have submucous fibroids sitting in the lining of the womb, then of course, we don't see that and take our eyes away. We'll address it directly. And options for management will differ. Of course, for a couple trying to have a baby, the options for addressing the fibroids will be more likely direct in terms of surgical, because many of the medications we use sometimes can suppress the hormones that will allow you ovulate and then release the eggs that you need for fertility. So the overriding conversation here is that not all fibroids will need to be addressed. Not all fibroids cause fertility, and you need to then see your gynecologist so that your gynecologist can evaluate and determine if the fibroids you have can be addressed to improve your chances of fertility. And then I want to state it here because a lot of women come in expecting that once the fibroids are removed, then it means that immediately they will get pregnant, or they've removed the actual thing that has resulted in getting pregnant. in an earlier conversation, we were talking about the role of each person in being responsible for delayed fertility. And of course, what the statistics are clear on is that the male and the female factor are equal contributors. Some will say 40 to 50%, some will say 30 to 40%. Whatever the percentage is, both parties are equal. When we talk about combined, we'd say about 20%. But interestingly, there's a 10% of couples that you would have evaluated and you can't find anything wrong, yet they can't get pregnant. And so sometimes you remove the fibroids. Everybody has pinned their hope on the fact that once you remove the fibroids, then that means, we've solved the problem and we should be able to get pregnant. I'm stating here that, 10% of couples, there isn't any clear reason that you can pick out. And of course, those ones, they're thankful for science, then there are other options available, and those should be explored. Right. Okay. So I think I have addressed the major concerns concerning today, talking about family planning and the role of family planning and fertility. Again, the recap is that family planning will not impact long-term fertility, particularly we are using long-acting reversible contraceptives. The other conversation we've had today is about PMOS, which we used to call polycystic ovarian syndrome. It could delay fertility, but it's not absolutely necessary that it will delay fertility. So what is important is have your regular unprotected sexual intercourse 2 to 3 times a week. Sometimes along that journey, a mature egg gets released and fertility can occur. If you've been trying for 1 year, you've not been able to achieve pregnancy, please see your gynecologist. And the primary method of management is first lifestyle adjustments. And then, of course, we've talked about fibroids and the role of fibroids in constant fertility. Thank you very much.
Definitely a contraceptive for you. Please engage with the gynecologist and understand better what might work in your case. She did highlight that the removal of fibroids may not necessarily be the resolution of infertility issues. Both partners are involved in making this happen. So, just to highlight that this is a collaborative work. There's a role for both males. Now to the next speaker.
He is an accomplished fertility specialist and the
event and the leadership of this church for inviting us. it's important that we take care of the whole man and not just the spiritual aspect. So today I will be talking basically about IVF. A lot has been said about fertility or infertility. We know the stigma that people place on infertility. Significance, it is important, we know. But just like Dr. Odesheye said, women are not just to give us kids. They also have lives to live. And we must help, excuse me, we must help them in living their lives outside the conception thing. We also know that it's God's desire, it's God's wish, it's God's will that we are fertile, that we give birth, just like he said in Genesis chapter 1, verse 28. And I won't start talking about infertility. Wow. Okay, I think it's this way. I won't waste time again on talking about infertility, causes and effects. Today, my colleagues have done justice to it. I would go to ART, which is assisted reproductive technology, which IVF is the main part. We have other parts. We have IUI, which is the simpler form or the initial thing that we consider for some couples. Who needs, or what is IVF? Let me start with that. What is IVF? IVF means in vitro fertilization. It means we are helping eggs to get fertilized without the tubes. I know someone would have talked about how that happens in the tubes and all that. But in IVF, the tubes are no longer needed. We get the eggs out in the lab and we inject the eggs with the sperm cells without opening up the woman. Because some people will wonder, how do you get the eggs out without surgical operation? No, we don't do that. We get the eggs out just like we're doing transvaginal ultrasound scan. We do know that all this have been talked about. I would like to emphasize this. Infertility is not gender specific. You know, we've seen cases in the clinic whereby the woman will come first. The woman will tell us that my husband said I should go and listen to what the doctor has to say and then go back. It doesn't usually work. The best is when the couple come in together to hear you. Because the woman can never, it's not possible, no matter how intelligent that woman is, you can't give detailed information that you have gotten in the clinic to your husband at home. So please, we want the couple to come. We have 2 chairs in our consulting rooms. I know we've looked into all this. So, just like I said, this is the simpler form that we consider first. We don't, when you come to the clinic, fertility clinic, we don't just say IVF. In fact, if we do that, a lot of clients will leave. They would not come back. So the first thing is, just like Dr. Odesheye would also say, the first thing we do is to assess. After the consultation, we assess, we do your investigations, we see what exactly is the cause of the infertility before we go ahead. Some people will just need counseling. After the counseling, they are fine. I've seen couples who will come in after their first consultation or the initial consultation. We don't see them again. By the time you call them, they tell you, oh, God has done it. And they've been waiting for years before coming. We've seen people, there's a couple I saw early this year. They live in Canada. She's been trying for 13 years, and she has done IVF cycles in Canada before coming. So we were looking at surrogacy for her. But alas, when she came, we assessed, did a perform ultrasound scan, we found the endometrium looked thin and all that, and then she went away. We're waiting for her to bleed so that we could start something. She did not. And we called her, okay, go and do a PT. We just said it. And alas, the woman got pregnant. She has had a baby. She had a baby just 1 or 2 weeks ago. So we are not God. We are not playing God in IVF. We are not God. God shows. God, we say that we care. God cares. God normally does that. And we see it a lot of times in the clinic. So in IUI, for anyone to be considered for IVF, for IUI, what we look at is, number one, the tubes must be patent. The client would have done HSG to show. I know some of us are, when you hear HSG, there's a fear. But we have places where HSG can be done without pain. If you don't want HSG, we have other things that can be done to assess the tubes without that pain. So if the tubes are patent, the man's sperm is also important. The sperm, there's a level or that the semen parameters must be. The count should be fine. The motility may not be optimal, but at least it should not be less than 25-30%. Then the normal form or the morphology should also be good. With that, the pregnancy rate or success rate for IUI is about 25-30%, just like what happens at home. It's just a bit better than that. Now, this is IVF. Just like I said, in IVF, what we do is we get the eggs from the woman, inject with the sperm in the lab. The injection is carefully done. There's a special machine, I'm sure it is, the picture is there. There's a special machine that does the injection with an expert. And after the injection, we culture for 5 days before we put back the embryos into the woman. Who needs IVF? Number one, if the tubes are blocked, don't delay. You've done HSG, you've done laparoscopy, they've confirmed the tubes are blocked. The treatment is IVF. Number two, if the couple have been trying for up to 3 years and nothing is happening, they will need IVF. The third factor is male factor infertility. If there is low sperm count or issues with the semen parameters and the couple have been trying for up to 3 years, they will need IVF. To the fertility journey. If there's azoospermia, there's a way we can go into the testes and get the sperm cells out so that we can use it for injection. So it's not the end of the world. And even if at the end of the day we can't find sperm cells, we still have things we can do. Just like for women, in terms of the eggs, there's always hope. There's always something to do in the fertility clinic. This is what I meant by the injection. The egg will be picked carefully, and then this is the needle. The needle is like microscopic. It's not visible to the naked eye. So it injects the sperm cells into the eggs. That's the machine that does that. And IMSI, I've seen some clients coming in to say that, oh, doctor, do you do IMSI? It's just like a terminology. IMSI just means morphology. By the aid of this same machine that does the initial one, you just pick the best, you increase the magnification so that you can get the best sperm cells for injection. Just like I said, for women who are above 42, let me use that as the cutoff. For 42, 40 and above, 42, we will advise that they consider gamete donation. People would ask, is it my DNA? Is it not another person's DNA? Before now, what people would do if there's infertility is to adopt a child. If you adopt a child, it's not your DNA. So this is still better than adoption. You have the eggs, is the woman that would get pregnant, is the husband's sperm in most cases. And if it is the other way, we've seen people who use eggs as donors and sperm cells as donors. And because of our society, if you adopt a child in this part of the world, you need to work on the emotion of that child. A day will come when they will tell the child you're adopted. But with this, nobody will know except anybody you tell that, so we use donor eggs or we use donor sperm. So we have new horizons in ART for intending couples who are both hemoglobin genotype AS, they can consider IVF. In this, we do what we call pre-implantation genetic testing, whereby you know which one is AS, which of the embryos is SS, and which one is AA. So we don't transfer anyone that is SS. We only transfer AS or AA. And also, I don't know how ethical is it for sex selection. Any child God gives you is a child. But for people, we call it family balancing, actually. You've had 2 boys, just like Dr. Deshaye's client, and you want a girl. It is possible with IVF. What we just do is, when we do it, we don't actually go to look for the sex or gender of the baby, of the embryo. What we look for, we screen, and when you are doing the screening, you also screen the gender, so it will be part of what we're going to get. So you know whether it is XY or XX. These are the miracles of IVF, the babies we've had, and this is just a tip of the iceberg. Thank you.
For him, please. Reiterating some of the critical points. If there are issues of blocked fallopian tubes, more than 3 years without, and exospermia, these are critical cases, or real cases, where you should be considering IVF, right? We've heard a lot this morning, and I would like to think that we've learned one or two things. We'll be going into a much more engaging segment of today's event. But before we go into that segment, I promised you some interesting information. Nobody reminded me, so I'll pass. Moving on. All right, then. Okay, so first of all, before I even give you that good news, I've just learned that we're not just getting information from these experts, and that they're not here alone. They've also come today with members of their team. Please, can you put a round of applause for these 2 institutions, Haviland and Cath Medical Lab and Maternity. Thank you so much for doing this. They've set up outside, and they're available to engage with you, to discuss with you, and then they're available for consultations, actually. Now to the interesting part. I thought you would give another round of applause. You see, the experts we have here today, they're very generous people. They're really very generous. We're very honored to have you in our midst. Thank you once again. They've said they're not also going to just bring their people. They're going to give us some incentives. They've made some concessions for us. From the fertility physician, we have been offered, this year Isolo campus, 20% off IVF treatments. In addition to that, there's a free consultation, with just a very small registration fee. Please, let's take advantage of it. Also from the gynecologist, we've received 40% off consultation, as well as a very small registration fee. Please take advantage of this. Go out there, book your appointments, ask questions, engage with them. They're waiting outside for you after the session, right? In addition to that, as you book your appointments, once you go to those hospitals, please remember to mention the code TCN Isolo. That's your code when you get to the hospitals. Thank you very much once again. Before we move forward to the next session, we'll take some very brief updates, very quick updates. Please allow me make welcome the team providing updates on expectant mothers. Thank you very much.
Everybody has one or two opinions. Sorry. But sincerely, for medical personnel, we know that some of these informations we see online, they are not really, really true and they're not correct. So that's the essence of this group. In this WhatsApp group, we have professionals, good professionals that will dish out good and adequate information on the group. So if you have questions, it's a safe space. You're free to express yourself, you ask your questions, and we have professionals who are there to reply to these concerns and questions as well. So this is the QR code. You can scan and join, and we're also seated outside. If you're unable to do this here, you can come and then join the group. If you also have questions about the group that you really want to know, we'll be free to answer those questions for you. Thank you.
Okay. Good morning, everyone. All right, and to our special guest, thank you so much. Thank you so much. God bless you. And thank you, everyone, for joining us live in this room today. And we also acknowledge those of you that are joining us online this morning via Zoom and also, on YouTube and also on MixLR. Wherever you're joining us from, we say thank you once again and welcome. Now, we trust that you're having a meaningful and transformative experience. Yes, yes. Do I have a witness? Absolutely. Fantastic. Yes, fresh perspectives. And we are grateful for this. Now, this Fertility Conference is brought to you by the Covenant Nation Isolo campus. Yes. CCN Isolo for short. And we are a daughter church of the Covenant Nation worldwide under the able leadership of our very own founder and senior pastor, Pastor Pajoye Made, and his lovely wife. Yes. Now, the Covenant Nation, for those of you who might not know, is a global faith-based Christian ministry with a growing presence across Nigeria, the United Kingdom, Canada, and the United States. Now, at the heart of this ministry is a simple but profound conviction that every believer can know Christ personally, understand who they are in Christ, and also learn how to live victoriously through the Word of God. Through our churches, our outreaches, and our online platforms, we combined sound biblical teaching with practical Christian living, while providing opportunity for meaningful relationships, spiritual growth, and personal care. Our vision is to teach Christians who they are in Christ Jesus and how to live victorious life in their covenant rights and privileges. We help believers become rooted and established in God's word, mature from milk to meat, from religion to reality, and ultimately become equipped to teach and empower others to do the same. Beyond the local church, the Covenant Nation expresses its mandate through conferences and initiatives such as this one. They include our annual, beginning of the year Global Feast of Ingathering, WAFBEC. Please look out for that. The next edition is on the 2nd to the 10th of January 2027. You don't want to miss that. We also have, other outreaches like the platform. Perhaps you have connected with us, where we discuss ideas that move nations forward and also businesses, enterprise forward as well. We have also the Covenant Capital Business School, amongst other things. We have other community impact programs, including the Lagos Seas, the EduAid, the Project RAP, and the Lagos Career Fair. Here at the TCN Isolo, this mandate takes on a deeply local expression, to facilitate the spiritual, relational, and material well-being of our members while becoming a blessing and a transforming influence across our community, of which today's conference is a witness to this fact. Now, we currently host here at this church 2 services every Sunday morning right here at the Covenant Nation Isolo campus. Our first service starts at 7 a.m. and our second service starts at 9:30 a.m. in the morning. We also have free bus services that commute members to and from designated points. Some of the details are posted on the screen, and you can check our pages. We have more information for you to take and join us. Now, we encourage you to feel free to ask help of any of our stewards and ushers in finding your way around. Also, we encourage you to look us up on social media. It's at TCN Isolo on Instagram, on YouTube, and on Facebook. Now, on behalf of our founder and senior pastor, Pastor Pojo Imade, and our campus pastors, leadership teams, and the entire Covenant Nation Isolo church family, we also call the Happy Church. Come on, let's show them we are the Happy Church. Yes. We are delighted to have you join us today, and we look forward to welcome you in any of our services tomorrow. And you can also fellowship with us at any of our campuses nearby to you. Just search on Google. There can be one very close by to you. Or you can just go to our website. It's insightsforliving.org. Insights, one word, insightsforliving.org. Once again, welcome to a place of learning, a place of transformation, fellowship, and impact. God bless you, and enjoy the rest of this conference. God bless you.
Cover all of the questions. To also make sure that the session we have now is as engaging, as insightful as possible, we may have chipped in a few questions here and there, and also to make some modifications to the questions so that it's very difficult to say or to identify who asked those questions where we thought was necessary. And so without further ado, please put your hands together as we welcome the experts back on stage to join us for this expert session, for this panel session, please. Okay, so we'll dive right into the questions. Like I said, we had over 130 to put these questions together, merge them. And so I may ask you a number of questions at once because I think that the topic is quite related. We're going to try as much as possible to respond within 2 minutes, right? Except where we see the need to extend further, but I would encourage we respond within 2 minutes so that we can take the much that we can today. All right. I'll be starting off with the basics. We had some very basic questions around menstruation and ovulation. Questions like, how does a woman know she's ovulating or not? Can a woman be ovulating and still see cervical mucus? And are period cramps and clots normal? How can she be experiencing pregnancy symptoms and look pregnant but not be pregnant? I'd like to direct that question, those questions to you.
I saw that coming. Yes. Okay. Menstruation, ovulation. How do you know? So I think the first thing I want to say is that we shouldn't get carried away with wanting to know when we ovulate in terms of symptoms, because a good number of women will not have any physical knowledge. That being said, what are the physical things that one knows that one has ovulated? There's this thing we call Mittelschmerz, that where you would, when the egg is being released from the ovary, there's an extrusion, and sometimes someone can experience that pain, and it can be quite sharp and obvious, and you feel it on whatever side that the egg is being released from. Now, with ovulation comes the change in the hormone levels, and so once you ovulate, then progesterone takes over in trying to prepare the lining of the womb for the potential implantation. That's when the cervical mucus changes, and you feel that stretchy cervical mucus experience, but not all women feel it. And so I think my overriding conversation is, instead of course, then the breast tenderness and some get more tired in that phase. Instead of focusing on that alone as well, is also understanding your menstrual calendar. Now, I'm a big advocate. Every woman has a phone, correct? Yes? And every woman's phone has a calendar, yes? My message to all women and their partners, because sometimes women come to my clinic, their husbands know their cycles better than the women themselves, and I love it for them. When the day you see your period is your first day of your menstrual cycle, pick up your phone, log it in there. There are apps that also do that for you, so if you have those apps, but please just validate the apps, because you know there are all types of apps, so please just be sure that you're getting a good app that does. So the day you see the first of your menstrual period, lock it in. And then, track your calendar like that. Now, for people who have regular cycles, the 14 days before your next period is coming is when you're expected to ovulate, not from the beginning of when you start seeing your period, because the first half of your cycle is what differs. The second half now, once a woman ovulates, 14 days after that, for 98% of women, 14 days after that, if a successful fertilization has not occurred, you would menstruate. So to know when you are going to ovulate, you calculate your period from when you're expecting your next period, not from the beginning. And that's why some women will have 28-day cycles, 32-day cycles, it will differ. So please don't calculate your ovulation period 14 days from the day you start seeing your menstruation. Instead, calculate 14 days from when you're expecting your next period, calculate backward to be more accurate. And of course, there's a window of 2 days before, 2 days after to allow for variations here and there. Someone asked if you can ovulate while you're menstruating. Was that? Pregnancy symptoms and not be pregnant. Yes, you can. Because there's Dr. Olagunju mentioned that there's a strong relationship between our emotions and our expectations and your physical body. So sometimes women have, believed so strongly about the pregnancy that all of a sudden you start manifesting pregnancy symptoms. Then not forgetting that some pregnancy symptoms are so basic that it could actually be an illness. And then in saying that, there's the hormone that makes you have a lot of pregnancy symptoms is HCG. There may be something else going on that is not pregnancy, that is making your HCG levels high, that can then make you have symptoms that may seem like pregnancy. So you just want to also get that checked out. So the more likely thing is that there's so much expectation around pregnancy that you are manifesting the symptoms of pregnancy without being pregnant. Then, of course, you could be basic medical illnesses. And then thirdly, the hormone HCG, which gives a lot of symptoms of pregnancy, may be elaborated in other conditions, and so that needs to be checked out.
Thank you very much. Thank you very much. So still on menstruation and menstrual cycle, some persons say, one of the questions we received was that, a person has experienced irregular periods right from childhood, and they're asking, what is the solution? Beyond that, we also have questions from persons indicating that they're around the ages of 36 to 39 or early 50s, and they have stopped seeing their periods. They're asking, could this be menopause? And apart from menopause, what else can this be? I'm hesitant, but would that be a question for you? A good question for you. We have a lot of women-related questions, so I'm trying not to. So if you find any question, within your comfort zone, please feel free to take that on. Anyone would like to take that question? Okay.
Right.
Okay, so I'll take that again. Irregular menstruation right from childhood.
Right.
And then women within the ages of 37 to 39 or early 50s who already have.
I think Dr. Olagunju did very, very, very good basic explanation of that from the very beginning. A girl child at the time of birth is born with all the follicles you're going to need for your entire life. So imagine a basket that has, a set number of balls in it. By the time one gets to puberty, which is the age at which your sexual reproductive functions and organs are better established, for a girl child, half of those follicles have gone atretic. That means they've dried up and gone away. So you have just that half left for the rest of your reproductive cycle. Now, at the time of puberty, your body's hormones are beginning to connect with each other to start the cyclical monthly bleeding pattern. Now, as with everything that is just beginning to start off, it takes a few twists and turns here and there before it becomes fully established. So for a girl child at the beginning of puberty, it is expected that for the first year or two, your cycles will be irregular because you have an ovulatory cycle you continue on, and that's the hallmark of menopause. And we define menopause as 12 months of not seeing a period at all, then you're menopausal. One very important element to also be aware of, before you get to that final destination, there is a precursor, which we call the perimenopausal period. So you have a critical number of balls that you need to function maximally as a female. As you get below the critical number, you start having some symptoms that give you, and that is also established by irregular cycles. So the beginning of your reproductive life, irregular cycle. Towards the end of reproductive life, irregular cycles before you get to the final point of no more menstruation. So very likely, from 40 years onward, if your cycles have stopped being regular, then very likely menopause.
Interesting. We still staying on menopause, on menstruation rather. I want to drive the conversation towards the male counterparts a bit, but before we go there, there are complaints about serious menstrual cramps since childhood. And the question is, how can we deal with this? In addition, questions around heavy bleeding, right, up to beyond during menstruation of up to 8 days, especially after C-section. Is that normal?
Right. Okay. So painful periods. So we can have painful periods classified as primary and secondary. Primary painful periods are usually along when a woman just starts her menstruation. Primary means there's no cause that you can hold responsible for it, except the normal menstrual pattern. Of course, there are some dietary things that can impact some of the hormones that get released during menstruation. Your prostaglandins and cold sugar tends to affect it and makes menstruation painful. Now, the other important part is what we call secondary dysmenorrhea, which is painful periods that is as a result of something. The main culprits are usually fibroids or endometriosis. If your periods shouldn't be that painful that they become debilitating, and interestingly accounts for 40% of women's absenteeism from school and from work. If you're having painful periods to that degree, please see your gynecologist so you can be evaluated so that treatment can be offered. Beyond the treatment of what is actually causing the pain, you can actually be given appropriate medications to handle the pain. The second question was about heavy menstrual bleeding. Now, the normal pattern that is expected for menstruation, yes, okay. The normal pattern for menstruation should be 2 to 7 days. If you're bleeding for more than 8 days, if you're bleeding for more than 7 days, it's not normal. Please see the doctor. If the volume of bleeding per day is beyond 80 mils, it's not so. If you're bleeding and you're seeing clump and clots of blood, that's not normal. And let's not normalize what is not normal. It's okay to see your doctor and get evaluated. After a cesarean section, if you're bleeding heavily, my recommendation is go back to see your doctor. You shouldn't be, and the pattern of bleeding after a C-section should be reducing with each day, and the color of the bleed should also change. So the first 2 days, you would expect some, heavy bleeding, but the bleeding should start changing in its volume and its color to light pinkish, and on until it totally disappears. So if you're still bleeding heavily after a cesarean section, please go get it checked out, because something may be on the line that needs to get sorted earlier rather than later.
Thank you very much for that. So, please, you can book consultations outside, and then let's start.
Sorry, it's very important to say that just make sure you're going to the right hospital. There are lots of gynecologists. I clearly can't see everybody, and the aim is not for everybody to, come to me. But I have, on one hand, I can list like 20, off the top of my head, 20 fantastic gynecologists that you can go see. So in your locality, because the aim is also not for you to travel long distances, because that will then make people not going to see their doctor. Because, if I have to travel from Ikoyi to Bagada to see my doctor, you won't keep up your appointments. You're going to fall through the cracks. So there's a gynecologist in every locality. Please find your gynecologist and then keep up with that. And family practitioners to family medicine consultants, they are trained and fully able to take care of our gynecological needs as well. I think is the other information I should put out there.
All right, thank you very much for that. You just spoke about hormones, and we know that hormones play a key role in ensuring that people get pregnant. How about low progesterone with women? Does it mean that they cannot get pregnant if progesterone is low? Also, can someone with high prolactin still become pregnant? What does elevated prolactin actually mean for fertility?
Dr. Alao, you want to pick that up?
Yeah.
All right. I would come in from the family medicine perspective, so that it doesn't seem like she's answering all the questions.
Please.
Okay. For hormones are very necessary, for fertility, especially the reproductive hormones, the progesterone, estrogen, prolactin, all those things come into play. There has to be a balance, they create the right environment for pregnancy to happen. So just like she said during her presentation, there's no absolute, in science. Yes, it's very low for pregnancy to happen. But when it is too low, or actually the prolactin you mentioned, when the prolactin is high, it's high tendency that pregnancy will not happen. High level of prolactin will prevent pregnancy. But there may have been some very occasional cases where, a woman could still get pregnant despite the high prolactin levels. So that's why I said there's really no absolute, but it's better to get a good balance of the hormones. So when there are imbalanced hormones, one should say the gynecologist or the endocrinologist. Yeah.
Okay, yes, it is. So if I was to just emphasize, low progesterone levels, it's a bit tricky because what does progesterone do in pregnancy? The role of progesterone is to support the pregnancy and to keep the uterus quiet for the entirety of the pregnancy until it's time for the woman to go into labor. It's not a heavy top liner for women who end up having miscarriages as a cause of the miscarriage. I know there's a lot of common conversation on that. They say I have low progesterone levels, so I need to take. It's like Dr. Laura said. It's not a heavy contributor. That's the word I'm looking for. It's not a heavy contributor in miscarriages or even preventing pregnancies. There are more likely, 20 other things that are responsible. And so I don't want everybody to focus on low progesterone levels. For prolactin, if your prolactin levels are high, what prolactin does is it inhibits the hormones that allow ovulation to occur. So if your prolactin levels are high, ovulation is likely inhibited. And you will see it in your symptoms. So you would realize you're probably not seeing a menstruation and you're having irregular periods. And so once that happens, then of course, go see your doctor, and then there are medications that can be prescribed.
All right. So still on hormones, let's just quickly address this as well. We had a specific question about combining cabergoline and aripiprazole. Now, I know this is a very specific question when treating high prolactin. Without necessarily, leveraging on this question to sort of answer for everyone who might be taking some sort of medication that would likely affect their hormones. What are the considerations that they need to make, actually, if they are looking to get pregnant?
I think that responsibility lies with the doctor because there's something we call drug-to-drug interactions. And so what we would ask the individual to do is lay all your medications before the doctor so the doctor can know how to manipulate your medications, avoiding drug-to-drug interactions. And what drug-to-drug interactions means that if you're on some certain type of drug, it can impact and affect the efficacy of another type of medication. So it's not something I can answer easily here and say, oh, use this or don't use this. It's just drug-to-drug interactions. Lay all your medications before your doctor so your doctor can juggle your medications properly to help you achieve maximum benefit of your medicines.
All right. Final question on hormones, and I will direct this to Dr. Lau, since we started to talk on it already. There are questions around low sexual desire, vaginal dryness, lack of ovulation, and all of that. The question is, what's the relationship between their hormones and all of this, and what can be done about it?
So, low libido, that's a low sexual drive, vaginal dryness. Yeah, the symptoms depend on low levels of estrogen, especially. Yeah. If anyone is experiencing that, yes, needs to see the doctor, the gynecologist. Because this is pertaining to the woman now. For men who are experiencing low libido, yeah, may need to get their testosterone levels checked as well, because these are sex hormones that, help you feel something, When the levels are low, definitely tells that, show him these symptoms that the person is experiencing. So what to do is to, of course, get assessed by the doctor. Yeah.
All right, thank you very much. We talked earlier about male reproduction. We had addressed female reproduction, and had addressed the fact that women within the ages of, say, 31 upwards could experience menopause. What is the similitude of menopause in males, and at what age should we start to make considerations as it relates to that? Anyone who would like to take that question?
Let me just, if someone can say something about what comes to mind is that, well, there's no menopause in men. Or there's no women.
We know the agree somewhere.
Okay, right. But it doesn't remove the fact that fertility may decline, as the man ages too. Yeah, the quality of sperm can also reduce as one ages. Yeah, especially once one is getting to 40 years and above, yes. But an elderly man can still father a child here.
Interesting. Does anyone want to add to that?
Yes.
Okay,
so,
please.
Let me just add that, just like you said, the quality of sperm and the risk of having children with some deformities, some genetic abnormalities, chromosomal abnormalities, increases with the age of the father. So I think they are ever fertile, in my opinion. An 80-year-old man can still, but what will be the quality of that baby?
You know what I find interesting? I've always found men actually go through a sort of menopause that we call andropause. And I think men have gotten... I think men have really gotten comfortable with the idea that they think they're entirely fertile. I don't know if anybody has read The Secret Lives of Baba Segi's Wives. If you haven't, please read that book. And that's all I'll say about that.
All right, thank you for attempting to balance the equation. Anyway, all right, so let's talk about couples, intending couples. One is thinking of taking a wife or a husband. What are the key tests that you recommend that they should take, sir? Questions for you.
Okay. I think I've been asked this question. I was asked a week ago about the investigations or tests to be done before they tie the knot. Looking at it, I know churches do hemoglobin genotype, infection tests, and all that. But it's difficult to do further tests. Will you ask the guy to go and do semen analysis?
So if you recommend, we will, actually. Just
So
tell
how
us
will
what
he
to
do
do.
it? Will the sister help him? How will he do it? How will he get the semen out? So those are the concerns.
They're encouraging him to masturbate.
To masturbate. So...
Okay. It's a very, very difficult question to answer, but okay.
Then, just like I said, the way I answered it on that day was, I think it should be more of openness. It depends on where we are, it should be openness. And then maybe they should also see a doctor, maybe a family physician, before going ahead, after doing all those tests. He or she will be able to ask some questions. Especially ED, erectile dysfunction. It's not impossible that a guy cannot even, do you understand? And then it is when the pastor has said, what God has joined together, let no man put asunder. And then they get to him, sister is saying, we must put asunder to this one.
Okay.
So the tests are actually not the tests that can be done easily.
So while you build on that, right, that question, I want us to also stay on erectile dysfunction and address what actually causes erectile dysfunction. But also, there's a question here that says, what causes sudden loss of erection during intercourse, and what is the solution?
I was going to build on the conversation he's had. And I understand why a lot of people had that, agitated response, because I see up to 10% of couples who are struggling to conceive, and they're coming in, and it's because the man has erectile dysfunction. He said something that is very critical that I wanted to emphasize on. Openness is so important. It's unlikely that a man who has erectile dysfunction doesn't know he has erectile dysfunction. You don't need to do a test to be told you have it. In fact, there was a couple that came into my office. The woman had never had sexual intercourse. So she had no idea what should be happening. And here's this young man, he had been deceiving her. Pretending. She didn't even know what penetration. I find that very hard. But she had no idea. And they'd gone on 2 years in their marriage. They'd never had penetrative sexual intercourse. And the woman didn't know. And so they came in because of infertility. And the woman would say, hey, am I the cause? And I was looking at this man like this. So that openness during dating is so critical. And erectile dysfunction can be caused by a lot of things. Sometimes medication, and Dr. Alao had a slide on that, talked about different medications, anabolic steroids, and things like that. So the conversation, and what we don't do a lot of in this country that I'm encouraging people to do, have a family physician, have somebody that is responsible for your health, that can tell you follow the history of your health, and then when something is out of sync, it's easier for the person to pick it up. So your first point of call will be to your family physician to see you, evaluate you, and then take it on from there.
Ladies and gentlemen, take him to the family physician. Thank you very much. Okay, so more questions for you, sir, related to this. I'm just going to reiterate the question. What causes sudden loss of erection during intercourse, and what can be the solution?
Just on a lighter note, maybe the man's bank account is down. Sincerely.
Do you mean to say that the bank balance is directly proportional to...
Not unlikely. But
right.
just like we said, the importance of having a physician, sometimes we also need to be tutored, sincerely. Women have come to ask me before that, why is it that it doesn't stay long and all that? And I would have to explain, okay, when you're having intercourse and you take your mind off, you don't know what is going on in the mind of the man. You take your mind off what is going on. There's no how. It will go down. And it's also a system by which you want to use it to also extend you understand? You say it happens, it comes. I hope there's no underage. If you're saying you don't want it to happen quickly, is what you would be advised to do. Just take your mind off what you're doing, and then, it's innervation, the nerves will the whole thing will go down, then you pick up again. You understand? But in this situation, most likely, it's not that. Most likely. Because if the woman is complaining, that means it goes down, and then to come up again, it's an issue. That's why she's complaining. I think it's a form of erectile dysfunction. It is. So some medications, just like we've said, antihypertensives, anti-diabetic agents, those things can cause, especially aldomate, can affect the erection. And then the disease itself could also, hypertension, diabetes, they could also cause dysfunction.
Thank you very much. Family physician, please add to it.
Just to mention a few things. Yeah, we've mentioned some of the causes of erectile dysfunction. We've mentioned something psychological causes, just like in the case of the bank account, or maybe the desire for the woman is no longer there. We've mentioned some medical causes, hypertension, diabetes, but there are some also lifestyle choices too, smoking, substance use, alcohol, all those things have a way of affecting, erection. Previous surgeries, there are a long list of things that can possibly affect erectile erection in men.
But there's definitely something that can be done to address this,
definitely,
right?
yeah.
Okay,
so you just need
fantastic.
to identify what the cause is.
Okay, so we need to see the family physician, understand what the cause is, and then address it. But please, one of the first things you need to do, women, is send money into his account. Let's rule out the bank account issue. Then we can move to the next item.
That's very important.
All right. So moving on, a child has had pain in their testes, and even 1 year after varicocele surgery, the pain still persists. What can they do?
They'll need to go back to the doctor. Sorry. So they'll need to go back to the doctor for re-evaluation. The child may need to see the urologist, the pediatrician again. Yes, just to be sure that there's no torsion, like in the process of having the surgery, something else didn't happen. Yes.
Okay. Would you like to take the question on secondary infertility? There's some question around that, and what exactly can be done regarding secondary infertility?
Okay, so secondary infertility, like was earlier defined, is the difficulty in achieving pregnancy again after being able to achieve conception before. And the different causes, I mean, it can be just like the scenario that was painted earlier, a no partner. So it may be from, you need to be sure that it's not from the other person. And then what is the age? The same questions you would answer for primary infertility, you would answer for secondary infertility.
Okay, fantastic. So please see your physician as well. Look through, discuss these issues with them and let them walk you through so that you're able to identify what the key challenge is, right? Okay. 3 failed IVF cycles. Even after a successful hysteroscopy, I hope I pronounced it well, okay. that one, yes. And all that treatment, yet no conception. I mean, this is a pretty sad case because this person has highlighted that such situations have led them to a divorce and even a remarriage, and still nothing. What can be the problem and what can we do to address this?
Obviously, you will agree with me that it's not a question that I can answer here or that can be answered there. It's usually something that is saddening, and even to the doctor, to the managing physician. So the first thing is we need to see the clients. Well, it's not impossible. I've seen someone who has done IVF 20 times, failed, more than 20 times. She has gone all over the world to do IVF, and at last, she has a son now. So we need to sit her down and identify the cause. Sincerely, we need to identify the cause. Where I don't want to say that she didn't go to good clinic. No, even the best centers, this can happen. You understand? So if we're sure that she's been well managed, we now need to look at a lot of factors could be responsible. One, we want to, for conception to take place, whether IVF or at home, you must have good embryos, and then the womb. It's not only let me just say the woman. Now, in case of the woman, or talking about the woman, you want to look at the womb. She mentioned hysteroscopy. That's one of the investigations that can be done to check the cavity, to be sure that the womb the lining is good. But we have other things. There could be autoimmune disorders that would affect implantation. So those are other things that can be looked into. And then demand too. Are we sure? What's the quality of those embryos? Sometimes they may look good, because you've seen cases whereby you have fantastic, when you look at them physically, they are good. But genetically, they may not be okay. So those are things that we need to investigate and be sure that we are good.
If the problem is genetic, by the way, is that something that can be assessed in Nigeria? And can
Oh,
be
yes.
Okay. So we can look at examinations that may not already have been done. Yeah.
I also want to then add the reality. Not everybody will be able to get pregnant, and it's important for us to say that. And that's why surrogacy is an option. That's why adoption is also an option. It won't be for everybody. And as I was listening to you about this particular woman, I want to give women the liberty to know when to say, I'm going to stop. I'm going to stop pushing my body. It's not easy to do 10 IVFs. Also remember that with each cycle you do, you're putting your body through something. We sometimes forget that. And I'm happy we're in church today. And Dr. Lagunje and Dr. Alawa have emphasized faith and medicine work hand in hand. We're Christians. We will pray about it. God will give us peace that at some point you will know, live well enough alone for now, and turn to Jesus to tell us what next to do. It is important as women, don't keep pushing your body till the point of no return, because guess what? There could be a point of no return. People have lost their lives in the bid of trying to get pregnant. I just thought it's important that I put that in there.
Thank you very much. This question comes up every now and again, but I would ask it today. Hopefully we can get the medical perspective from faith-based people, right? Is IVF possible for mature singles? Is it restricted to married couples? What then is the hope for unmarried women in this conversation? Sir?
Absolutely. Now, let me come to the ethical aspects. We are in church, but I won't look at the... Unfortunately, we have ethical guidelines in Lagos. Fortunately, we have ethical guidelines in Lagos State that governs IVF. Single women are allowed, and in some parts of the world too, are allowed to have IVF done without a partner. But single men, no, they are not allowed. Because every child has the right to have a mother. Anybody can be a father. So even for adoption, she just said it now that adoption, women are allowed to adopt, but men are not allowed. You can't go as a single man to adopt a child. So women, for IVF, the same thing happens. I've turned down so many cases of men coming in to say, oh, I'm single. I say, go and get a wife. At least have a partner. But women can come in, they are mothers. That child needs a mother. So the other way too, women have an age whereby we say no. In Lagos, it is 55 years as of today. We say no, we cannot, and the man can be 80 years old. So it's not like it is one-sided. That's a part of the one for the women. At age 55, we are not allowed to actually conduct IVF on the woman. But the man can be 90 because we want the child to have a mother that is still able to take care of the child that still has energy. I love what Dr. Odesha, and it gave me in fact, it changed my perspective about, we should not just, I must have a child. Thank you, Dr. Odesha.
Okay. Still on IVF, just before you put off the mic, still on IVF. We're going to go around, definitely, and I'll go back and forth. So please don't get bored. And the questions will come back to you. But still on IVF. The question is, are there spiritual concerns with using donor eggs from an unknown woman? They don't understand her lineage. They don't know if there are witches there, right? And what measure do doctors take to screen and match these donors? Should we be concerned about spiritual issues? Have you heard about such before? Otherwise, what should we be concerned about?
It's a question I've been asked over and over again. But looking at it as a believer now, just like Dr. Desha said too, we can go to God and understand what exactly He wants you to do. But medically speaking, what I ask clients is, I've seen cases whereby it's the man, the woman does not mind, it's the man that will say, oh no, I can't go ahead if it is not my wife's eggs. And after 1 year or so, that man moves to another woman. That new woman, what investigations, or did you do genetic testing on that woman? Did you go to their village? Those days, in the olden days, maybe they were doing that. They would go to the lineage. They would say, what, did they have this in their family? But now we don't even do that again. Because some of those things are not actually genetic. If you want to do genetic testing, we can do genetic testing. If you want us to do genetic testing on the donor before using that, we can. It's possible. We'll just analyze. But at the same time, as we are doing that analysis, we should analyze the man's own too. So we are sure there won't be issues. If she is a carrier of an ailment, the man does not also have. But before, your husband and wife, we don't do that. So why do you want to now, because we now say donor eggs, you are now asking questions that girl in their family, do they have witches, or are they mad in their family and all that? Unfortunately, in this part of the world, we don't keep, anything the lady tells us is what we will take. There's no way we can investigate. We don't have record of families, the father, the mother, so it's not possible. But what you would just do is to believe God. If this is what God wants you to do, it will work. We have seen cases of couples who have used donor eggs, and they are fine. Excellent.
Thank you very much for that. Okay.
the additional balance I wanted to put in there, it's not an unfair question to ask, because the reality is you don't know where the donor is coming from. And so expectedly, there are some questions or evaluations you need to, because there's medical history. Now, the difference between when it's your own egg is, even if something shows up later in life, you can ask one grandfather or one auntie, do you know was there a family member like that? That element is taken off. And so the balance is the faith and the medicine. Let the medicine do as much evaluation as they can. And then you go on your knees in prayer. And because this thing is about grace too as well. Because there are families where it is your egg and the child is problematic throughout the child's life. That you're even, and I'm serious, that at times I even say, which kind of child did God give me like this? And it's your egg. You don't have control of that. And that's why the balance of faith and medicine comes. Let medicine do the evaluation that they can do. Then you're a praying child now. Go on your knees and pray. Looking for that donor egg, let the lines be matched onto me for pleasant places, so that the egg that comes before you is the one that is chosen for you.
Thank you so much. Thank you so much. I mean, I don't think we could have found a better topic for today's event. Thank you all so much, and even better speakers or experts than we have on this podium. Thank you so much. Thank you. To the pediatrician, a child is obese with dark skin on certain areas, like on the neck, and this child also have irregular periods. Do the parents need to worry?
Oh yes, they do, because that's already signs. Yes, telltale signs of PMOS. So there has to be caution, and just to reemphasize the need for good nutrition. There are a lot of junks now, and it seems as if our children are now our bosses. They are our ogas. They're the ones that tell us what to do and how to train them. So we may need to get the steering back from them and redirect them, particularly because they come into the clinic and the mother is helpless. I'm like, okay, 12-year-old, 100 or over 100 kilos. Oh, yes. And then 15 over 100 kilos, no periods or irregular periods once in 4 months. And I'm like, okay, the first thing, you need to go to the dietitian to map out a better nutrition plan and then exercise. Oh, doctor, she will not answer me. She will not. Yeah. So it seems we underestimate the future implications of some of these things from the outset. And it is the earlier, the better, really. So that's...
Thank you very much for that. Mothers, please, can you activate your African motherhood? Research statistics exist now. Use it. Anyway, thank you for that response. But I want to, reiterate one of the points in that question. She said dark patches on the neck. People in Nigeria believe that, you can give birth and you have birth marks. Is that also an indication, or are there marks that we should look out for?
Okay, so the dark patches we may need to reevaluate. I would have assumed that may be like acne, and part of some of the features of PMOS would be hirsutism. So having hair pattern, male hair pattern in females. So hair along the chin, like having beards and things like that. So it may just be a precursor for that. Like something that is going to happen. So, the dark patch, I'm not sure exactly what the dark patch could mean, but we may need to bear that in mind. Yes.
All right, fantastic. If you have questions here in the auditorium, please feel free to write them down, and you can even pass it to the ushers. Okay, please, let's do that immediately. Let's do that right away if you have questions. Another question, this question is for the family physician. Can having HIV impede one from having children, especially for a woman who's had children before now? Does having HIV now, can it prevent her from being able to
Do you mean
pregnant?
the man or the woman?
I think you can respond to it from both perspectives.
Okay. HIV does not directly impede fertility. That one is HIV positive does not directly impede fertility, both in the man and the woman. And that's why HIV parents can give birth to children, but It can also, the transmission can be prevented in the child though. I think that answers the part of the HIV regarding fertility. I don't know, what's the other question?
No, they've had children before. Can it impede? That's just the question.
Okay,
and
well,
HIV stop
like you said,
having-
HIV does not directly impede fertility. There may be other factors why they are not having, where they are now having secondary infertility. They get a long list of other things. Yeah.
Okay, all right, fantastic.
So if I could just add my thoughts on that as well, is that there's HIV and there's AIDS. HIV is having the virus. AIDS is when the virus has permeated your entire system to now cause clinical symptoms in different organ systems. So HIV in itself, no, can't impede fertility, except the person's virus load is high enough and you're not able to have sexual intercourse because you don't want to infect your partner. Then, of course, if you're not having sexual intercourse, and of course, there are ways around it, and that's where Dr. Bamidele and his team is readily available, and other IVF specialists. So if you have HIV and your levels are high, then of course assisted reproduction is an option where they can then retrieve to avoid sexual intercourse. But then if you then have AIDS defining illnesses, then that can impact on erectile dysfunction and all of those things.
Yes, that's true.
Okay, thank you very much. If you do have questions and you want to ask directly, feel free to put up your hands at this point if you've not written down. Yeah? Okay, so that's one. Is there any other person who wants to ask a question? Two. We can only take one more. Any other person? Three. Please, can you help pass a mic? Thank you very, very much. While we're trying to get the mic across, let me quickly take this question. Someone in their mid-40s who have been trying to have kids for about 5 years. They have fibroids. They've done all sorts of investigations and treatments. They're looking out for options. And they're also asking, is natural conception still possible? Okay, happy to pass it over to you.
Okay, so for them, I think she can still achieve conception, especially at home. Just like Dr. Desha said when she was giving us the lecture, we need to know where exactly the fibroid is. Is it in a position whereby it could impede implantation and conception? So she needs to be evaluated. At 40, mid-40, it's going to be a lot difficult, but it's still possible. It's still possible. If they now find it after evaluation, if it is still difficult, there's nothing disturbing the fibroid, is not, because she just mentioned fibroid. Maybe she did an ultrasound scan and then they said there's a fibroid and all that, and she felt that could be the cause. That may not be the cause. So they need to be evaluated, and then, if need be, we're available, would see what can be done. Okay. But at that time, it's going to be IVF.
Oh, you have a question for you? We'll take it.
So I wanted to ask you from your own experience. So from a gynecologist's point of view, we say 45 onwards, your egg quality and egg count is not practicable. And so when I see patients, we do AMH. The AMH is low or no normal. From your experience and patients in that age category, how many of them have you successfully, ratio-wise or probability-wise, how many of them have you really been able to use their eggs to be able to achieve successful conception?
While you're answering that question, because it relates very close to the question here, which is, what is the percentage success rates of this IVF SEF? You understand?
I think I will start with, with that.
All right.
Globally, the success rate of IVF is about 30-35%, sincerely. 30-35% is better than what happens at home. But some centers, we've been able to do above that, much above that, far above that, about 50%. First quarter, don't let me go to personal stuff now.
Okay.
We've been able to do close to between 50 and 60% in some cases. And, so many things will be considered when you're looking at it. We have, especially in this part of the world, just like this question, people who are 42, who are 45, I want to use my eggs. 50, I want to use my eggs. And then you listen to them. for them is a form of closure. Let me just see. I know it may not, but I know what God is saying. And then we go ahead. That will affect your success rate. But in our clinic, we can put them aside. Such people.
Categorize them, yeah.
Exactly. So outside that, above 50%.
But among that age group, what would you say is the success rate?
After 42, the chances are actually less than 1%. I've seen at 42. I've seen a woman using her eggs and achieving conception at 42. But after 42, 43 and above, I think between 1999 and 2020, I learned of one case. And I was also outside the country. I asked the same question that we've said after 42. I was asking them in that clinic. They started IVF long ago. They were able to count on one hand how many 42 and above they've been able to treat successfully.
Chances are slimmer, significantly slimmer. All right. I did ask for questions, and I do have a good number of questions here. So I'm going to crave the indulgence of our experts. You spent some good time with us, but it also means that the people in this room trust you and believe that you are answering their questions and can answer some more. So we might stretch this a bit more if you don't mind. If you do, please let me know. Otherwise, please relax. Drink a cup of water. Drink water, right? And then we'll quickly run through some of these questions. Here's what I'll do. We'll take one question from those in the room, and while we're trying to pass the mic to another person, I'll read from the questions that I have here. But please permit me to start with this question before we take yours. And this is for the pediatrician. We have a child here who has had acne since 4. They visited dermatologist, and, those concerns still persist. And she started having this, from a very tender age. Obviously, 4 is also tender. Can this possibly affect her fertility? Is this an indication? Should the parents be considering the impact, or whether this is any indication of issues with her fertility?
Okay, so I would want to assume that this acne in coat is something we call atopic dermatitis, and it can be sometimes difficult to treat. It's just one of the symptoms or one of the features on the spectrum of allergies. So it has nothing to do with infertility. It has nothing to do with that.
Okay. Would you recommend this see a gynecologist? A pediatrician anyway? No?
They're already seen a dermatologist.
Yes.
Yes,
okay.
so that's fine.
That's fine. All right. Thank you very much for that. Over to you, sir.
Hello? Okay. Thank you very much, everyone. You've been wonderful, our panels of experts. Thank you so much. It's A and B. Sorry, I just have to ask. One is a question, and of recent, we're hearing things like deodorants, hair cream, that affects, especially the ladies. It affects how their fertility, whether they can get pregnant in the future. But these are things that are used, everywhere. How you can't escape it. One cream, body cream, hair cream, deodorant, spray. How will they escape that? Because from stories we're hearing, these things are actually affecting the fertility of ladies. So that's the question. The other one is, you might not have an answer, but what would you say? Because there was a time when my wife was pregnant, we knew someone, and one of the things she just said is that she lost twins, and she did everything. And the thing that struck me, she said, but there was one mad woman that stayed in a gutter that gave birth. And you're saying have lifestyle choices, this. The mad woman is not doing all that, while the person that is doing all that still lost twins. And it's really pained her. So I'm just trying to, what do you say to those kind of people when those things come up? Thank you.
All right, thank you for the questions. So for the first part of the question, there's no we don't have data to really tell how much of all these cosmetics, affect fertility. But it's important to know that we have to be careful with things we buy to, use on our bodies. We have to verify the products that we use, whether on our bodies or even the things we eat. One of the things I mentioned in my slide is, exposure to, environmental toxins. I mentioned pesticides, herbicides. That's for people who are into agriculture, most likely. Even people who work in some industries, exposure to some heavy metals. And some of these products too can have some of these things in them. They may not really say these things obviously in those products, but we have to, be very vigilant and be careful with these things. We should go for verified products if we're going to, sometimes you can ask your doctors like, okay, or bring the product to your doctor, let you and the doctor go through the contents of, what you're using and be sure they're not harmful to your bodies. Not just for fertility, but for, other things. The second question about, okay, a mad woman giving birth to babies while someone who is seems to be normal is not, is having difficulty to get pregnant. Yeah, so the fertility is a function of biology, really. It has nothing. It has very little to do with mental states. It's about the biological function of the body. Yeah, so someone must have gotten her pregnant, though. Yeah, so yeah, it's a you may say that okay, she gets to eat dirty things most of the time, but what about the person that is not doing all that, but is also engaging in some lifestyle activities that harm the body? What's it called? Using some very harmful products. A mad woman would likely not go for things that would be harmful to the body. It's just for her to eat certain things. Fine, may not get she may not get
Hygiene.
Good hygiene and all that. She may not have sexually transmitted infections because she's not taking care of her body. Most of the problem will be on the outside of the body. I don't know if you get that. But again, it also all boils down to divine, God has a way of doing his own things. Yeah. So, so I was just trying to explain some things in the medical way. But again, at the end of the day, we are all creatures of God.
All right.
Yeah.
Thank you very much. So question for you now. I know we've talked about women who are above 40s, and I'll talk about that a bit more, but what can a woman do who has fibroid inside her womb and has intramural fibroid, actually? What can she do?
So to answer simply, if you have fibroids that are impacting on fertility, get it removed. It's a simple answer because, going through a surgery is a big deal. And so let's not underplay that as well. And so it's not something to just walk into with say, I'm just going in for a surgery. But I think this is where, seeing your doctor and being practical with yourself as well comes into play. Because I've had, people come to me 3 years ago, they had fibroids. They were more manageable at the time. But, God forbid, it's not my portion to do surgery. They run away. But guess what? They come back. Because one of our analogies in medicine is that ignorance is not bliss. Simply wishing the problem away doesn't take the problem away. They come back 3 years later, the fibroids are much bigger, it's more complicated. And guess what? That surgery you ran away from 3 years ago, you're still going to do it. So if you have intramural fibroids, like I said earlier, and what all of us have been reiterating here, is to evaluate and determine, does it need to be taken out? Once that determination has been established, then it's got to be taken out.
Question, yeah. What's the difference between clogged blood and fibroid? Does clogged blood affect menstruation?
Clotted, okay, so what's it? They're not the same thing.
Blood clots.
Blood. Yeah, they're not the same thing. So like we've established earlier, one of the common symptoms of fibroids is heavy menstrual bleeding. And usually when you're bleeding that heavily, the blood then tends to clot. And so if you're having heavy menstrual bleeding, it's not normal. It needs to be addressed. Now, the question is, what is causing the heavy menstrual bleeding? If it is determined that it is the fibroids, and so sometimes I tell patients, it's not even about fertility. If you have fibroids that is causing you to bleed that significantly, whether you're interested in having children or not, that fibroids needs to be addressed. And so there's a difference, is that if you have fibroids, it can cause you to have blood clots. And if that is happening and it's that significant, you can lose so much blood that you become severely anemic. And remember that the role of blood for us is to help us with our daily functioning, because blood carries oxygen to all your vital organs for them to function. So if you don't have enough blood, you're not having oxygen to help your vital organs function, and that can be detrimental to your health.
All right. So consider your overall health and do something about it. Now to the second question. Do we have Mike? Yeah, please go ahead.
So I'll first of all say thank you to our panelists. Thank you so much. My question is this. If in a case of endometriosis or diffuse adenomyosis, and from my knowledge of it, in some cases they would suggest that you can use medication. In some cases they would say surgery. What if the person does not want to go through the route of surgery? When does it get so bad that you can no longer maintain with medication and you have to do the surgery? Thank you.
So to that, let me just put a bit of context to what adenomyosis and endometriosis is. So the lining of the womb that sheds every month is called the endometrial lining. That lining is meant to be only within the lining of the womb, so that every month when the egg is released and 14 days after, when there's no pregnancy, it can shed off as menstruation. Now, sometimes what happens is that lining of the womb is found in other areas beyond just the lining of the womb. So one of the commoner areas it can be is within the ovaries. It can be within the pelvic cavity itself. It can be in the eye. It can be in the brain. It can be in the lungs. I have managed patients who've had endometriosis in the brain, had it in the lungs, and we've had to go in surgically. So imagine that scenario where the lining of the womb that is supposed to shed every month. So it will shed. So wherever it finds itself, it will shed. So what would that mean? You will bleed in your brain. You will bleed in your lungs. You will bleed in wherever the lining of the... So that's endometriosis. Adenomyosis is that lining of the womb that is... Now, the womb has 3 layers. The outer layer, the middle layer that someone was talking about, intramuscular, and the inner layer. The inner layer is where the lining of the womb is meant to be. Maintain your lane. Now, if that lining of the womb is within the muscle area, that's what we call adenomyosis. Of course, that also comes with symptoms, because now you're bleeding within the muscle of your uterus when you're bleeding every month. Now, one of the basic principles of medicine is there's never one absolute way to do anything. And with patient autonomy now, the patient gets to decide what they want to do for their bodies, because it is your body. As much as we're medical professionals and we have the knowledge as to what is likely best to be done, our job is to counsel you on what the best option is, the pros, the benefits, and what the alternatives are. Your job is, what am I best comfortable to doing? With endometriosis, it's tricky, and usually the pattern of endometriosis management is you start out with something, use it for a couple of years, it stops working, you switch plan. Surgery is not always the answer for everybody. If we're going in for surgery for a patient with endometriosis, it's very clearly defined. And in fact, surgery is not our first option because of the nature. And so if we're going in for surgery for endometriosis, it's very specific. Adenomyosis is a bit different because adenomyosis, if it's localized, it's easier because the purpose of surgery is to address something. And so if you can't clearly define what you're going to address, then don't go in for surgery. We use medications. Unfortunately, it's a waxing and waning thing with endometriosis. Sometimes you get good seasons, sometimes you get really difficult seasons, and we keep managing like that until you get into menopause. Sometimes the bigger issue with endometriosis is over time you bleed into the pelvic cavity, it causes and affects other organs. So it's not even just about, it's a tricky one, and it has to be individualized. I hope I've been able to kind of,
Yes, I mean, you've educated all of us at the end of the day, so definitely I'm sure you got something there. All right, so we have a number of women-related questions, but we do have, opportunities to meet with, have consultations outside, and so I would encourage us to take advantage of that. I'm just going to take quickly these questions that are more related to men. It says, what can be done to increase sperm motility? And if you've been trying for years and all the tests indicates everything is fine, what can you do? Can I direct that to the family physician? And then the final question I'll take from this list is, as a new dad, this dad wants to understand the negative effects of pressing a female genitals of a baby with hot water, not warm water, hot water. Can it affect their fertility in the long run? I'm sure that's a cultural thing. Yeah, so starting with the first question.
Okay. Thank you. For sperm motility. Okay, from the family physician's perspective.
Sorry, can I ask that we answer the question in just 2 minutes as
okay,
briefly as possible?
First thing, or the most important thing is lifestyle changes. Family physicians are very big on, emphasizing on lifestyle choices because he has a way of affecting her health a lot. So lifestyle changes, lifestyle choices are very important. And secondly, once it's discovered that it's poor sperm motility, the causes need to be, determined. So it's also important that you see the doctor, get assessed, then get treatment depending on what the cause is. Yeah, sure, definitely.
Thank you. All right.
Because they have a way of picking the right ones.
Exactly. So maybe that's something to consider. All right.
So as regards the hot water, I'm not sure it has anything to do with fertility, but more of the safety of the baby. So let's be sure that we're not going to do something that will cause burn injury. I know that it is cultural, maybe grandma doing something that she did for the forefathers that worked, but let's just be sure that we're playing safe with the baby.
All right, fantastic. I'll just summarize it as stop it. Please stop it. Don't do it again, please, for our sake. Thank you very much. I know you're being diplomatic. Let me help you. All right, so we have one more question in the audience. We'll take that quickly. Please, can we have a mic passed across to him? Or provided to him then? So we have, that's number 3 there, yeah?
Thank you so much. Sorry. Thank you so much to the panelists. I just have to ask this question. I'll try and make it brief. I have a friend. She's married, and she had her first child through some pains. She has fibroid. Now, her sister went in for fibroid operation and died. So she's having the phobia of not wanting to do an operation. But she's really, during a period, she's highly affected. She's in pain. She lost blood to a point where you could see physically that she's emaciating. But she doesn't want to do operation. So now, how do you convince her? Because when I was coming, I told her to listen to this program. So how do you convince her to do an operation? Because the fear, the fear is a phobia of what happened to her sister.
This is how I help people make decisions, benefits versus risks. Everything has a potential for risk. And so when you're making a decision, the question to ask yourself is, does the benefit outweigh the risk? When the benefit outweighs the risk, then you give yourself the opportunity to go ahead in spite of the risk. The other question to then also determine is, what is the probability of this risk happening? You know how some risk is 1 in 1 million, while some are, 5 in 10. But the baseline is the benefits versus the risk. The second thing I'll tell your friend to do is, it's a real fear and it's not something that can just magically go away. But what I would recommend you do is, please go to a center, a hospital that has a reputation for being good at what they do. Fortunately for us in Nigeria, fibroids is common in our midst. The average gynecologist in Nigeria knows how to handle fibroids. The question to then ask about her sister's case, howbeit it's very unfortunate, was where did she do the surgery? Who did the surgery? What were the circumstances? Maybe that would help her. So if you're going to a good center, and there are 1,000 good centers in Lagos that can do a good fibroid surgery, the question you should be asking in the hospital, who is your gynecologist? What is your setup to be able to do a safe surgery for me? Do you have blood setup? Do you know all those? Do you have an ICU? Because again, the risks are there. And so it's not to pretend like the risks are not there. They are there, but is that setup equipped to be able to manage that risk? And again, as the primary question, who is the gynecologist? Is it a gynecologist? Is certified, in Nigeria, as with other professions, things happen. People claim to do or can't do what they can't do. But then to ask ourselves, the benefit of the surgery versus the risk, and this bleeding every month, she can die from losing blood consistently that way, and that is a greater risk than if you go to a good hospital with a good surgeon to do the surgery.
All right, thank you so very much. Thank you very much. Do our panelists deserve a round of applause at this point? Yeah, thank you. Thank you. Thank you. It's really been a very interesting, insightful time. Thank you so much for making the time, for being here today. Allow me to apologize for those who sent their questions here and were unable to take them. You agree with me that they spent quite an amount of time, even beyond the scheduled time. And we also need to show respect for their time and the other activities they have to carry out. So thank you very much. This brings us to the end of the session. We'll be taking quick pictures, quick photograph. May I ask that the pastorate, the head of the medical team, join us in taking the photo.
Thank you so much. You can have your seat. Where do I start? First, I want to thank you all. Dr. Olua Lagunju. Right from, I just posted it on the HOD's, the global medical group, and said I needed a pediatrician. And immediately, without asking questions, you see, you people I love Dotisi and Isolo. Immediately she responded and, she accepted our invite. Thank you so much. Dr. Alao, I don't know how I'll thank you, but I will say thank you. Dr. Alao has a personal engagement today, but because you people in TCN Isolo and even online, you people are loved, he shelved his own personal engagement just to be here. Please, let's appreciate Dr. Alao. God bless you. Dr. Adesumbo Odesheye, you may not know the relationship between the two of us. She was my roommate in medical school. So she came here today to harass me. Every time she just keeps saying, it's because it's you. It's because of you. I mean, if those that were on the webinar knew that she was in the office and they were saying, doctor, she was like, give me 5 minutes. Give me 5 minutes. So she gave us her time during the webinar, and she's also here today, even fully with her team. Dr. Adesumbo, we appreciate you. Thank you. And last but not the least, Dr. Bamidele Babatunde. He is my mentor. Even in the midst of all this planning, he was asking me, so what's next for you? What are you doing? And Dr. Bamidele, I've worked with him for years, and he has been an inspiration to me. And he's also a pastor, so you would have detected it from the way he spoke. Dr. Bamidele, thank you so much for coming. God bless you. We want to appreciate all our specialists for the time they've spent here. And especially we want to say thank you to CAF Maternity and Laboratory Center, as well as Havila Fertility Clinic for giving us concessionary prices for our treatment. Please, let's give them a round of applause. So please, those of you that are here, it's like you have expo. As you are coming out, just go to their stands, write your name down. We are not even asking you to make payment or anything. Write your name down, register your interest. Don't let all this information and freebie go to waste. Why? Because the offer is valid for just the next 3 months. We don't want to, leave it open-ended and there's a lot of confusion, so that there is, they can pay particular attention knowing that you are coming from TCN Isolo. And remember that the code word is TCN Isolo anytime you go to approach the clinics. Also, I want to appreciate every volunteer, every worker in TCN Isolo. Give yourselves a round of applause. Everybody has been so fantastic, going up and down the place, making sure everything is working well. You are highly appreciated. Finally, I want to appreciate the medical team. This is an idea that has been birthed over the last 3 years. And we've just been thinking about it, how are we going to do it? And finally, it has come. I know I send messages to you at 2 a.m. in the morning. Somebody like our collaterals flyer designer, he will avoid me for like the next 1 month. I accept. But thank you so much, everyone. And on behalf of TCN Isolo, we would like to declare this seminar closed. God bless you on your journey as you go home. We expect miracles, signs, and wonders. God bless you all. Bye.